This conference will now be recorded.
Hello? Hello?
Hello?
Hello?
Hello,
Hello?
everybody. Is my
Hi.
voice is clear?
Yes, it's clear.
Yeah, and the
Yes.
screen also clear?
Yes, please.
Okay, that's good. Hello, everybody, and welcome all of you. And thanks for attending my session. And it is my pleasure to be with you for the next time. First, I want to introduce myself. I'm Dr. Rasha Homida. I'm a specialist OB/GYN in the International Medical Center in Jeddah Hospital, and it is a tertiary hospital. Okay, and I know it is a very precious time for you now. So just keep all mute, and if there is any questions or any things, just let it at the end or write it in the chat or in the group. Okay. So let's start. Today we will complete. We will just go fast because I know there is no time. Okay. Because we have nearly 90 questions, we want to solve it from EMQ to SBA. First, we'll start by the tubal and the uterine surgery. And just I will give you brief, just the highlight, which is for the mild tubal disease, tubal surgery may be more effective than no treatment. Okay, and it will be in the center with appropriate expertise. And for the proximal tubal obstruction, we can do either selective salpingography plus tubal catheterization or hysteroscopic tubal cannulation. So just concentrate on mild tubal, proximal tubal, and what you will do for them. Okay, we know for the hysterosalpingogram, salpings before IVF, we will recommend for it. We will offer salpingectomy. Always came in the EMQ and in the SBA questions. Regarding the uterine surgery, also, if in the scenario came to you and the patient was, for example, she had the previous DNC and means that she was Asherman syndrome and there is intrauterine adhesion, so that we will offer hysteroscopic adhesion analysis. This is very important, okay? And for the medical and surgical treatment of endometriosis, as we know, the minimal and mild, we will do minimal and mild endometriosis diagnosed as the cause of infertility doesn't enhance fertility and shouldn't be offered. So medical treatment will not be done for minimal and mild endometriosis. Okay. For the surgical ablation, women with minimal or mild endometriosis who undergo laparoscopy should be offered surgical ablation or resection of the endometriosis plus laparoscopic adhesion analysis because this improves the chance of pregnancy. Okay. Then for the ovarian endometrioma, as we know, laparoscopic cystectomy to improve chance of pregnancy. And for moderate or severe, we will offer surgical because also improves the chance of pregnancy. Okay. And regarding the post-op medical management, doesn't improve the fertility. Okay. For the unexplained infertility, what do you mean by unexplained infertility? Means that the woman with having regular unprotected sexual intercourse for a total of two years, okay, including the 1 year before their fertility investigation, before IVF will be considered. So it means that if the patient came to you 2 years, okay, with unprotected sexual intercourse, and there is no any, all the investigation were normal, so that at that time this is candidate for IVF.
Dr. Rasha, please, I want to clarify with you this point that the investigation 1 year, what does it mean, this one?
This can include up to 1 year before their fertility. Means that usually we will investigate after 1 year. Okay? Usually we will investigate after 1 year. So if the patient came to you after 1 year and the investigation done after the 1 year, it's the 1 year that was without investigation, it will be included. Okay?
No, I didn't get it. Sorry.
For example, they are newly married now, came to you, and they complete 1 year. Okay?
Yes.
Usually, you will not investigate unless 1 year complete or there is a problem. Yeah? So,
Yeah.
now 1 year, and we will start to do the investigation. Okay? They spend with me in the clinic for another 1 year. So, after this, the another 1 year, with the first 1 year, it will be counted. Okay?
Okay.
You understand it?
Yes, thank you, Doctora.
Yeah, thank you. The intrauterine insemination, this is we mentioned it before. The indication for intrauterine insemination, no need to go again on it. This is the intrauterine insemination, the catheter, as you saw here. Regarding the prediction of IVF success, this is very important. From the start, what is IVF? Actually, IVF is a procedure done to overcome, designed to overcome infertility and produce pregnancy as a direct result of intercourse, of intervention, I mean. Okay, what are the prediction for this? The female age, number of previous treatment cycle, previous pregnancy history, and body BMI. Okay, regarding, as we know, if increased age, this means that the success with IVF will be decreased. According to the number of the previous treatment cycle, it should be counted with each IVF cycle. Okay, and regarding the previous pregnancy history, IVF treatment is more effective in women who have previously been pregnant. Okay, and regarding the BMI, it should be ideally 90 to 30 before commencing assisted reproduction. Okay, let's go. Yes, lifestyle factor. This is very important, as we said before. The consumption of more than 1 unit reduce the effectiveness of the assisted reproduction, including IVF. Okay, yeah. Also the maternal smoking and these things. Yeah, the criteria for referral to IVF. This is very, very important question and came always in the exam. Okay, the NHS criteria. Anybody know about the NHS criteria for referral to IVF? Okay, so the criteria for referral to IVF, this is, you should know it by heart because it is important here and also important in the third part. Okay, you should know that the IVF criteria referral is that the BMI of the patient shouldn't be more than 30. The patient shouldn't be a smoker. The patient also shouldn't have a children from this pregnancy, or I mean from this partner or any previous relationship, and also the age wise. Okay, because every age have a specific number of IVF cycle. Am I clear?
Can you repeat it?
Criteria for referral for IVF. This is very important. The NHS criteria. Age should be specific because the age is important in the prediction success of the IVF, and also each age range have a different number of cycle of IVF. Okay. The third thing is that the BMI shouldn't be more than 30. When you come to refer patient for NHS criteria, okay, means that it will be funded by the NHS. Okay, it shouldn't be BMI more than 30, shouldn't be smoker the patient, and not have a children from this partner or any previous relationship. Okay, then here, this is, I think it is not too much important now. Just we'll go fast on it. Woman age under 40.
معلش ICSI.
We will come to it. We will come to it. Okay. The indication and everything. Okay, let's go fast now. Okay. Woman age under 40, if have not conceived after 2 years of regular intercourse or 12 cycle of the artificial insemination, you will offer 3 full cycle of IVF with or without XC. So this means that woman under 40. Okay, if the woman reaches the age of 40 during treatment, complete the current full cycle, but don't offer partial full cycle. Okay. Then woman age 40 to 42, this is an area of exam, an area of questions. So a woman age less than under 40, we will offer her 3 full cycle of IVF with or without XC. Okay. Then woman 40 to 42, if haven't conceived after 2 years of regular unprotected intercourse or 12 cycle of artificial insemination, okay, you will offer 1 full cycle of IVF with or without XC. After what? Fulfilling this criteria, they have never previously had IVF treatment. There is no evidence of low ovarian reserve, means that her ovarian reserve is normal. There has been a discussion of additional implication of IVF and pregnancy at this age, means that we will counsel the patient regarding the problem and the complication with her age with the IVF. Okay, this is also, you should know it carefully, because the scenario always, these things, it will be included in the scenario. They will give you the ovarian reserve of the patient. He will tell you that she did before IVF, so that you will consider this in solving the question. Okay. Then, as we know, where investigations show that there is no chance of pregnancy with expectant management, and where IVF is the only management, you will refer the patient immediately to specialist team for IVF treatment. What do you mean by cancel IVF cycle? Actually, cancel IVF cycle means that when an egg collection procedure is not undertaken. Okay. For example, if there is signs of ovarian hyperstimulation syndrome or something like that, we will cancel the cycle. Okay. Then the procedure used during IVF: consider pre-treatment in order to schedule IVF treatment for women who are not undergoing long down regulation protocol. Okay, we have two protocol. I will tell you here. It is either long regulation or down regulation, short regulation. Okay, this is to avoid premature LH surge in IVF. This is the benefit or the aim from this down regulation. This is very important point. It is very important in the question when you solve the question. For the down regulation, to avoid, what is the aim of the down regulation? To avoid premature LH surge in IVF. Okay, what you will do, you will use either GnRH hormone agonist down regulation or gonadotropin releasing hormone antagonist as part of the gonadotropin stimulated IVF treatment cycle. Okay, so if you will use gonadotropin stimulated IVF treatment cycle, you will use either the GnRH agonist or releasing hormone antagonist. Okay, only offer gonadotropin releasing hormone agonist to women who have a low risk of ovarian hyperstimulation syndrome. Means that she is not, for example, PCO, because agonist is a risk factor, one of the risk factor of the ovarian hyperstimulation syndrome. Okay, and when you will use GnRH hormone agonist, you will use a long down regulation protocol. Okay, now we will come to the to know what is the long down regulation protocol. I will show it here, just 1 minute. Here they said that for example, use of ovarian stimulation as part of the IVF treatment. Why we will use ovarian stimulation? This is very important in the IVF. I want to tell you, in the unexplained infertility, you will use a natural cycle IVF treatment, but generally you will use ovarian stimulation as part of the IVF treatment because it have a higher pregnancy rate as per cycle than the natural cycle IVF. This is a very important point you should know. Okay, so you will use either urinary or recombinant gonadotropins for ovarian stimulation as part of the IVF treatment. Okay, and it will when you use this FSH and gonadotropin, you will consider the age, BMI, presence of PCO, and ovarian reserve. All this should be considered with this medication. Okay, don't use FSH more than 450 international unit per day. Okay, and you should offer ultrasound monitoring, okay, throughout for the efficiency and the safety throughout the ovarian stimulation. Okay, this is also very important. This is the GnRH agonist, for example, bezarline and neferline, and GnRH antagonist. This is just you know it. No need now to mention it. Gonadotropin also, this is available in the form of, as we know now. Yes, this is here the concept of the ovarian stimulation IVF, cycle IVF, okay? The stimulation means that we will achieve, this is achieved by human menopausal gonadotropin or FSH, okay? Means that the follicular stimulation and proliferation by this is stimulation. What you will do, you will spontaneously, the spontaneous ovulation, because the patient, she had a spontaneous ovulation. This will be blocked by GnRH agonist or with GnRH antagonist. Okay, so the aim of the human menopausal gonadotropin or FSH for ovarian stimulation, and the aim of the GnRH agonist or GnRH antagonist is the spontaneous to block the spontaneous ovulation of the patient. This is a very important point. Okay. Then the long and short. The long, this is I think I didn't saw it in the before, but just I want to tell you that it is the long protocol is that often with GnRH agonist and involve starting medication in the menstrual cycle before the IVF cycle. So you will start the long protocol in the menstrual cycle before the IVF. In the short protocol, you will start at the start of the menstrual cycle in which IVF is performed, and it is the GnRH antagonist is the preferred one. Okay. This is actually the long protocol and how it is work, and it is just briefly, if you know that you first the GnRH will be used, as we said before, the GnRH we will use it for the block of the ovulation. Okay, so we'll use it for 2 to 3 as the red arrow. Okay, and then the down regulation is confirmed by the presence of a thin endometrium. Okay, and then after that and lower plasma estradiol, then the ovarian stimulation is commenced, okay, with either MHG or recombinant FSH, which as you saw with the green one, okay, and then the HCG. This is to induce final maturation, as you see, the one arrow up with the HCG, and then the ovum pickup, okay, is arranged for 34 to 37 hours after final HCG administration, and then you will check the endometrial thickness, as we said, to return back the this embryo. Okay.
Doctora, can you repeat it slowly?
I want to repeat the slowly actually, but no time. That's why I want to spend with you the question. Okay, but I will do it for you again. No problem.
Yeah,
this is the long protocol.
The arrow. You use the arrow just to
Yeah, the arrow. Okay, the arrow actually the red one, as you see this one, the red one. Okay, as we said before, it will this long protocol it will be done or it will started before the cycle, as we said. So here, before the cycle, all this area, okay, before the cycle, we will use GnRH for 2 to 3 weeks to desensitize the pituitary, okay, so that we will block the ovulation. Okay, so all this red arrow, and then the down regulation is confirmed in the presence of a thin endometrium and a lower plasma estradiol level. Okay. Then ovum stimulation, you will do it by the gonadotropin, as you see here, the greenish arrow, and then the HCG or recombinant LH, okay, to induce final maturation of the oocyte. Okay, and then the ovum collection is arranged for 34 to 37 hours after final HCG administration. Okay, then the ovum pickup, and then we'll check the endometrial thickness. And on here in this area, we should after the HCG, we should monitor by the ultrasound. Okay, and then after that, the endometrial thickness to be checked for the embryo transfer. Okay. This is the same, the short protocol, as we said. It will be started from the start of the cycle. And the same scenario is that we will start by GnRH and agonist here, okay? Analog agonist, and then After that, we will do go for the ground trophy with the greenish one, if HMG or recombinant FSH in the early menstrual phase, okay, and usually on day 2 or 3, okay, and then the HCG, and then the ovum pickup, the same. Okay, let's go. Now here, the triggering ovulation in IVF, okay, the same as we said now. I will offer HCG to trigger ovulation in IVF, sorry. And then after that, offer ultrasound of monitoring of ovarian response to check for risk of ovarian hyperstimulation syndrome, okay. And then after that, he said now here that women undergoing transvaginal retrieval of the oocyte should be offered conscious sedation because it is safe and acceptable. And here also, women who have developed at least 3 follicles before oocyte retrieval shouldn't be offered follicle flushing. This is just as to know.
Dr. Rasha, can I ask you one question?
Yes.
Regarding previous slide, when you were explaining about short protocol, is it GnRH antagonist or agonist that you are using?
We said before, as we said, we said before here in this slide, you see here, just 1 minute. In the comparison,
Long protocol, it is
the long protocol,
yes,
it
yes.
will be GnRH agonist, and this is the antagonist. Yes. Yeah. Okay.
Yeah.
Yeah.
Okay. Okay. Thank you.
Thank you. Welcome.
Dr. Rashad, I have also one question. Sorry to disturb you. Actually, I just want to ask that we have. Can we use any protocol for anybody, or is there any specific reason that we use long protocol or short protocol?
Actually, there is
how
no.
this patient is suitable for short protocol or long protocol?
As I understand that, because here, for example, in the as you see here in the long protocol, yeah. In the long protocol, you will use GnRH agonist. Okay.
Yeah.
So from this previous slide, we said that. 1 minute. Here you see, when using GnRH agonist as a part of IVF, use a long down regulation protocol. And this is actually in case of, for example, if you have, for example, ovarian PCO, you will go, more likely.
Okay.
Yeah. If, for example, patient have PCO, you will go for the antagonist because there is a risk of ovarian hyperstimulation. This means that you will go with the short one. Okay.
Okay. That's great. Thank you. Thank you.
Yeah. Thank you. Sorry, because I want you to solve more questions, my dear, because I know your time. Because we have nearly 90 questions. Just 1 minute. This is just I like some point that assisted hatching is not recommended, for example, and also this one in the IVF shouldn't offer ultrasound guided embryo transfer, and regarding the replacement of the embryo with an endometrium of less than 5 is unlikely to result in pregnancy and is therefore not recommended. Okay, and this bed rest more than 20 minutes doesn't improve the outcome of the IVF treatment. Okay, this is the same which we said it before, and this luteal phase support after IVF, so that you will offer progesterone for luteal phase support after IVF treatment. Okay, and don't routinely offer HCG for luteal phase support. Okay, because of the increased risk of ovarian hyperstimulation. Okay, and that evidence doesn't recommend or support continuing any form of treatment for luteal phase support beyond 8 weeks of gestation. Regarding who asking about the XC, actually this is the indication for XC, which is severe deficit in semen quality, obstructive azoospermia, non-obstructive azoospermia. XC should be considered for couple in whom a previous IVF treatment cycle has resulted in failed or very poor fertilization. This you should know it by heart. Okay, where the indication of for XC is a severe deficit of semen quality or non-obstructive azoospermia, the man's karyotype should be established. This is very important. Okay, because this means that you will go for example, cystic fibrosis or these things for Klinefelter.
We use it then when there is fail in IVF, or
when there is very poor fertilization or failed,
okay.
yeah, IVF, you can go next the second cycle for the IVF with XC. Okay.
Thank you.
Yeah, because maybe sometimes there is unknown cause. For example, there is problem with the sperm. So better, because this is precious for the patient, and also the IVF cycle, it will be counted for her. So to increase the chance for this success. Okay. XC versus IVF. XC improve fertilization rate compared to IVF alone, but once fertilization is achieved, the pregnancy is no better than with IVF. This is the donor insemination, okay, is considered in managing fertility with the following condition: obstructive azoospermia, non-obstructive azoospermia, severe deficit in the semen quality. Donor insemination, also the same. I think this we said it before. Now here, yeah, this is for donor insemination. You should confirm when you start for the patient donor insemination. You should make sure that the patient is ovulating from the start. Okay, and also if there is any history of tubal damage, should be offered tubal assessment before treatment. Okay, and if there is no risk factor in their history, you should offer her tubal assessment after 3 cycles. If treatment by donor insemination hasn't been unsuccessful, this means that after 3 times of donor insemination, you should assess the tube to see what's the problem. Okay, and also couple using donor sperm should be offered intrauterine insemination in preference to intracervical. This is just an area because it will improve the pregnancy rate. Okay, this is before we said this point. Yeah, oocyte donation, this is very important. As you know, one of the most question every time come for the Turner syndrome, because there is ovarian dysgenesis. Okay, so the use of donor oocyte is considered effective in managing fertility problem associated with the following condition: premature ovarian failure, gonadal dysgenesis including Turner, bilateral oophorectomy, ovarian failure following chemotherapy or radiotherapy, certain case of IVF treatment failure, and also should be considered in certain case where there is a high risk of transmitting a genetic disorder to the offspring. I saw your question that you said semen analysis is very bad. Repeat as soon as possible. Now, when you do karyotyping, as we said, that if there is fail, for example, or there is any problem in fertilization during the IVF process, so that at that time you will do XC, you will give XC. Okay. Okay. Sorry. Yeah. Risk factor. Okay. Yes. Just I want to see if there is any question. Sorry. Okay. So when using cryopreservation, yeah, during IVF, yeah, exactly, during IVF, if there is any problem during the fertilization, yeah, okay, that means that maybe the problem is the sperm. Okay, when using cryopreservation to preserve fertility in people diagnosed with cancer, okay, you will use sperm or embryo or oocyte, and at the diagnosis, you should put in your mind the impact of the cancer and the treatment between the person and diagnosed with the cancer and their cancer team. Okay. Use freezing in liquid nitrogen vapor as the preferred cryopreservation. This is we have question. I think that before they said that what you will use the preferred technique for the cryopreservation. Just you know that it is the freezing in liquid nitrogen. In liquid nitrogen, because it came that liquid some substance instead of nitrogen. Okay, freezing in liquid nitrogen. Then offer oocyte or embryo cryopreservation as appropriate to women of the reproductive age who are preparing for medical treatment for cancer that is likely to make them infertile if they are well enough to undergo ovarian stimulation. Means that the patient she is not very sick, or this will not worsen her condition, or there is enough time available before the start of their cancer treatment, for example. Okay. Then this thing which is often, yeah, this is very important. You will store
Dr. Rasha, the voice is very low. The voice is very low.
Okay, here is okay. Now is okay, my voice?
Yes,
voice is clear.
That's fine. So store cryopreserved material for an initial of 10 years. This is very important. And offer continuous storage of the cryopreserved sperm beyond 10 years to men who remain at risk of significant infertility. Okay. Regarding the long-term health outcome and safety, this is just, you should know that the absolute risk of long-term adverse outcome of the IVF treatment with or without XC are low, but there is a small increased risk of a borderline ovarian tumor, and it couldn't be excluded. Okay, that the absolute risk of long-term adverse effect in children born as a result of IVF.
Sound is not clear.
Now not clear.
رشا بس ابعد السماعه شويه، الصوت
Clear
كويس
يا رشا.
بس علي الصوت.
Okay.
Clear,
So,
clear.
Yeah.
It is
So,
clear يا رشا. It is clear.
That's fine. So inform people who are considering IVF treatment that absolute risk of long-term adverse outcome in children born as a result of IVF are low. Okay. And then also limit drugs used for control ovarian stimulation and IVF treatment to the lowest effective dose and duration. Means that during the ovarian stimulation medication, you will use the lowest effective dose. Okay. So finish the nice infertility. We'll go for ovarian hyperstimulation, and then the last one is a PCO, and then we'll start the question. The ovarian hyperstimulation is a complication of a fertility treatment, as we know. The mild one is 1/3 of the cycle, around 1/3 of the cycle, while the combined incidence of the moderate or severe varies from 3.1 to 8%. Okay. The early ovarian hyperstimulation syndrome usually presents within the 7 days, as we know, and is usually associated with excessive ovarian response. This is the early. The second one is the late, present 10 or more days after the HCG injection, and is usually the result of the endogenous HCG. Means that from the physiological HCG derived from an early pregnancy. Late ovarian hyperstimulation is tend to be more prolonged and severe than the early form. This is the history and symptoms, as we know: abdominal bloating, abdominal discomfort, nausea, vomiting, breathlessness. Okay, this is important. I don't know, I didn't bring the, yeah, I want to show you this, the severity of the ovarian hyperstimulation, as this is no exam without the classification of the severity of the ovarian hyperstimulation. You should this paper by heart. Okay, the mild is abdominal bloating and mild abdominal pain, and the ovarian size is less than 8 centimeters. You can pick up from the scenario, just you go for the ovarian size, and that the site is clinical or by checked by ultrasound. If it is by ultrasound, means that is moderate. If it is clinical, means that is severe. Okay. Then for the critical and severe, you can, for example, you can separate them, or you can compare by them with the, for example, acute respiratory distress. He said to you, for example, the patient cannot breathe, or for example, there is osmolarity less than 2.82 for the severe, and sometimes he came to you with a hematocrit. Hematocrit is more, for example, than 0.55. This is very important, this figure. Okay. Also the investigation here, as we know, it is very important for the electrolyte disturbance. Okay. What are the risk factors for the ovarian hyperstimulation? As we know, previous history of ovarian hyperstimulation, women with polycystic ovary syndrome, increased level of anti-Mullerian hormone, increase antral follicle count, IVF cycle employing GnRH agonist, and multiple pregnancy. Okay. Regarding the management should be appropriately the patient counsel and provide information regarding fluid intake and output. Non-steroidal should be avoided. This is very important point. Just I put the most important point in this actually session. Non-steroidal should be avoided, as we know it will compromise the renal function, and you will give her this one thromboprophylaxis. Okay.
This slide, it's not clear.
Just make it a little bit big, okay? Sorry.
Dr. Rasha, one question in the previous slide, one question saying AMH is very high, more than 25. So what could be the result outcome? It's high OHSS and high pregnancy outcome, or it is, can you just let us know?
About what? I didn't understand.
There was one recall question saying anti-Mullerian hormone is very high, more than 25, they said. And what is the outcome of this? The options were like high OHSS and high pregnancy outcome. The rest was like less outcome and less OHSS, like this. So for
yeah, we solved it before this question actually.
Just
anyone can answer this question? Yeah.
Both are high.
Hello.
Severe
outcome of the pregnancy.
High ovarian stimulation syndrome and low pregnancy outcome.
Yeah. Yes. Exactly.
Okay.
Yeah.
Thank you, Doctor.
Okay.
Thank you, Doctor. Thank you all.
You are welcome. Thank you, Doctora. Also, Doctora Hala. Okay. So, sorry for this, but just make it big, the picture a little bit. So you should know about regarding the thromboprophylaxis, the duration of treatment should be individualized, okay? And as we know, if the patient with severe ovarian hyperstimulation, you will give the thromboprophylaxis for the first trimester, as we know, okay? And paracentesis of acidic fluid may be carried out on an outpatient basis by abdominal or transvaginal route under ultrasound guidance. And also encourage to drink to series rather than a set of amount of fluid. And fluid intake, at least 1 liter a day should be advised, okay? Then medical review to assess severity if the
Excuse me, Dr. Rasha. For about the fluid intake, at least 1 liter per day. Yeah, encourage her to drink means I didn't understand the meaning. To drink a lot or to drink less?
To drink less. To drink to series.
Okay, thank you. Okay,
thank you. Yeah, welcome. So medical review, yeah, if it came to do the scenario and they said to you that the urine output is less than 1000 ml per 24 hours, or the fluid balance, okay, the positive fluid balance is greater than 1000 over 24 hours, this means that you should go for medical review. Okay, this is very important because it can come in the EMQ. Then paracetamol and oral opioid, including codeine, can be offered to women for pain relief instead of the non-steroidal. Okay, analgesia and antiemetic also you can give it for the patient. Okay, this is just I make briefly that is the indication for admission and that the indication for paracentesis. Maybe you can read it. Okay. Yeah, this is the strategy to prevent ovarian hyperstimulation syndrome. This is from the talk. First of all is that choice of treatment. Okay, as we know, the gonadotropin-releasing hormone agonist is one of the risk factors of ovarian hyperstimulation. Of ovulation induction, okay, and also in IVF regime, for example, like regimen, for example, GnRH antagonist by using of the antagonist. The costing. What do you mean by costing? Anybody know? What do you mean by costing? Okay.
Withholding 1 or 2 doses of gonadotropins.
When the patient has a serum estradiol of more than 4,000, or she developed more than 3 follicles more than 18 mm to prevent OHS.
Yeah, excellent, Dr. Prisana. Okay, so costing means that it is a practice actually in the IVF treatment where the gonadotropin are withheld. Okay, and HCG is administered, or means that administration of the HCG is delayed until the serum estradiol decrease to a safe level, which is less than or equal to 12,000. Okay, this is the costing. So this is one of the regimen to decrease to prevent ovarian hyperstimulation syndrome. If he ask you, just you know that it is to withhold the gonadotropin, and you start or delay the HCG until the level of the estradiol is safe level, which is less than or equal to 12,000 picomole. Okay. The third thing is the triggering oocyte maturation with GnRH agonist in antagonist cycle, and then single embryo transfer and the luteal phase support using to see HCG versus progesterone, and other like metformin, dopamine agonist, cycle cancellation. All these are strategies to prevent ovarian hyperstimulation. It can come to you as in a single best answer or EMQ. Then PCO, we'll talk about it fast. What is prevalence of PCO? PCO is one of the most common endocrine disorder in women of reproductive because of different in the diagnostic criteria employed for PCO. It had a wide range of prevalence from 22.2 to as high as 26%. In the top written, it is 10 to 18%. Please mute yourself, please. Sorry. Just 1 minute. Yeah, thank you. Okay, so more in Caucasian South Asian present at young age and severe symptoms. Insulin resistance is present in around 65 to 80% of women with PCO. This is very important, and independent of obesity, and is further exacerbated by excess weight. How it is diagnosed? As we know, anybody tell me how it is diagnosed?
Hello. It is by Rotterdam criteria.
Yeah, 2 out of 3 criteria. Yeah, you can tell me. This is very important, actually.
Patient
Yes, I want you to
oligo or
revise it. I put it to revise it, okay? Yeah, tell me.
Okay.
It is diagnosed with the help of Rotterdam criteria. It should be minimum of 2 out of 3 criteria with polycystic ovaries and ultrasound, with follicles 12 or more, or increased ovarian volume of more than 10 cubic centimeters, oligo or anovulation, and clinical or biochemical features of hyperandrogenism, like hirsutism and acne.
Yeah, this is very important, actually. Okay, this definition. And then the symptoms, as all of we know, oligo or secondary amenorrhea, hyperandrogenism, hirsutism, these things. You know, all of you, I think you know this. Yeah, here this is very important because it comes in the, I think, in the exam. Acanthosis nigricans show insulin resistance. This is very important. Skin change with the PCO patient. This is very important because it comes one of the SBA. Okay. Investigation, we know regarding the this one, androgen index. The calculation, total testosterone divided by sex hormone binding globulin by 100 by sex hormone binding globulin. Okay, and also this is important, hysteroscopy and end sampling, endometrial sampling, if more than 7 millimeter or polyp. This is very important also. Okay. Then we will go for the, yeah, this is actually just, I want to revise with you these points because it's very important in answering the question of the EMQ. For example, if in the question came to you that if there is sign of virilization, deep voice, reduced breast size, increased muscle bulk, clitoral hypertrophy, okay, or rapidly progressive hirsutism, it came in the actually the EMQ before, that rapidly progressive hirsutism means that less than 1 year between hirsutism being noticed and the seeking medical advice. And or total or high total testosterone level greater than 5 nanomole or more than twice the upper limit, okay? If one of them, you will go for 3 differential, okay? From these 3, you will go either for androgen secreting tumor and late onset or non-classical congenital adrenal hyperplasia, and all these should be excluded, okay? Regarding the 17, as we know, the androgen secreting tumor, what is the second thing that it will be more with androgen secreting tumor? The HIA. Am I right?
Yes.
Yeah.
Yes.
So
Yes.
we finish androgen secreting tumor. We will go for this is the other with PCO. 17 hydroxyprogesterone should be measured in the follicular phase and will be raised in congenital adrenal hyperplasia. Okay. However, it is possible to have congenital adrenal hyperplasia without the testosterone being greater than 5, especially if the woman is heterozygous for this condition. Okay, this is important. Then, when you will measure, hence measurement of 17 hydroxyprogesterone should be considered if there is a high index of suspicious. For example, a specific group such as Kawasaki, Jewish, or those with a family history of congenital adrenal hyperplasia, since the management of congenital adrenal hyperplasia is different than that of the PCO. So if 17 hydroxyprogesterone is borderline, okay, to confirm congenital adrenal hyperplasia is by the ACTH stimulation test. Okay, it is very, very important and you should know it by heart because this is a guideline.
Can you repeat this point, Dr. Rasha, the last point?
The last point is that, so as from the previous, this one, we said that sometimes we can find that 17 hydroxyprogesterone should be measured in the follicle, as we know. Sometimes it is possible to have congenital adrenal hyperplasia without testosterone being that greater than 5, especially in the heterozygous for this condition, for the congenital adrenal hyperplasia. Okay, so
Dr. Rasha, excuse me. Dr. Rasha, excuse me. From the beginning, the patient came with symptoms of this or signs of rapid progression of the. From the beginning, can you repeat it, please? From the beginning of the slide.
Okay, I will repeat it. If there is sign of virilization, means that you have a deep voice, reduced breast size, increased muscle bulk, clitoral hypertrophy, or you have rapidly hirsutism, means that less than 1 year. When he said to you that there is rapidly progressive hirsutism, means that there is less than 1 year between hirsutism being noticed and seeking medical advice. Okay? Or there is high testosterone level, means that the testosterone is greater than 5, okay, or more than twice the upper limit. At that time, you have 3 differential, either androgen secreting tumor, late, or a non-classical congenital adrenal hyperplasia. Okay, so all of these should be excluded.
Okay.
Hello. Just 1 minute. Okay, so as we said that we should exclude. Then regarding the congenital adrenal hyperplasia, we know that by the 17 hydroxyprogesterone, it will be raised. Okay, but sometimes he said to you that it is possible to have congenital adrenal hyperplasia without testosterone level is high, means that at this time we should think about the heterozygous for this condition. Okay, yeah. Then after that, he said to you that 17 hydroxyprogesterone should be considered if there is a high index of suspicious, for example, like Kawasaki Jewish or those with a family history of congenital adrenal hyperplasia. Okay. Then he said to you, if the 17 hydroxyprogesterone is borderline, you will go for ACTH stimulation test.
To confirm, Doctora, to confirm the diagnosis of late onset of congenital adrenal hyperplasia.
Yeah.
But if it's high, it's enough. That's for diagnostic. If it's high.
Yeah. If it is borderline, you will go by ACTH because you are doubt.
What is the normal level they will give it us in the exam, the question?
Yeah. Don't worry about the level. Oh, the level will be there.
Okay.
Nice.
Dr. Rasha, this ACTH stimulation test is the same as the synectin test?
Yeah. It is the same. Yeah.
Okay, thank you.
Okay, thank you, Dr. Rasha.
Thank you, Najwa.
رشا معلش البيت الرينج عشان نعرف البوردر لاين ما ضروري تدي كم ال 17 هيدروكسي بروجسترون هو الافريج كده في حدود كم عشان نكون عارفين انه ده بوردر لاين.
As I know that he didn't want from you to know it is he will say to you that 17 hydroxyprogesterone is borderline.
No, Dr. Rasha, one question is given this number.
The range. Yeah. He said to you, this is borderline, this is normal, this is borderline, this is high. Okay?
Okay.
Dr. Rasha, this ACTH will be high in congenital adrenal hyperplasia, or it is for the Cushing? What will the result come then? If it is borderline, we'll go for the ACTH stimulation. Then how we will diagnose it congenital?
What?
You said if this borderline comes, 17 hydroxyprogesterone, then we go for the ACTH stimulation test to diagnose congenital hyperplasia. So my question is this: the result of this, how it will come? ACTH stimulation test. It is high, or what we diagnose is congenital?
Yeah, it will be high. Yeah, it will be high. ACTH.
So the differentiating point with the Cushing syndrome, if it is related with the central obesity, acromegaly, then we go toward their side. Other we will say congenital adrenal hyperplasia, like this ACTH stimulation.
Yeah, exactly like this. Just if it came to you, this is stimulation is high, it will diagnose congenital adrenal hyperplasia. If there is clinical suspicion of Cushing or acromegaly, you will go direct for the specific investigation for each condition.
Dexamethasone,
Yeah, excellent, Najwa. Excellent.
Sorry, Dr. Rasha, what about ovarian hypertrichosis?
I will tell you. Just let me to finish because you have, I think, question in the question.
Dr. Rasha, ovarian hypertrichosis, the diet will be normal, and testosterone is more than 8.7, the level high testosterone, and the diet it's a normal level.
Yeah, exactly. It is actually a premenopausal condition. Okay. Yeah. So answering your questions, I don't know Hala or who.
Okay, thank you.
Thank you. So just a brief about the PCO to be screened for type 2 diabetes. Excellent, Najwa. Thank you. So woman with PCO be screened for type 2 diabetes. Okay. If the patient with PCO get pregnant, you will do for her GTT at 24 to 28 weeks. Just for revision. Need annual screening for type 2 diabetes if BMI is more than or equal to 25. And PCO, women with PCO who are not overweight, BMI less than 25, but who have additional risk factor, such as advanced age, more than 40, personal history of gestational diabetes, or family history of type 2 diabetes. Okay. Need 75 oral GTT, as we said, and the impaired fasting glucose will be 6.1 to 6.9, or the impaired glucose tolerance, it will be plasma glucose 7.8 or more than, but less than 11. After a 2-hour oral glucose, diabetic if more than 11. The management, just I make it briefly, depend on the symptom and fertility wishes. Okay, it's very important, and it will be by a team of gynecologists, dietitian, nutritionist, and exercise specialist midwife, endocrinologist, mental health team, physician, and surgeon if needed. Refer to endocrinologist, mental health if depressed, and infertility specialist, bariatric surgery. Okay, lifestyle modification for weight loss, diet, and exercise program. And if in the weight loss, if the BMI is more than 25, weight reduction by diet and joint exercise group may need pharmacological agent. Okay, 5% loss of body weight in the first year will improve clinical outcome. Okay, and decrease insulin resistance and testosterone level. This is very, very important point, that 5% loss of weight in the first year will improve the clinical outcome, decrease insulin resistance and testosterone level. Okay, and then medical treatment, weight reducing drugs like metformin, so clomiphene and metformin for ovulation induction, Mirena, progesterone or CHT for withdrawal bleed. Okay, and surgical treatment, for example, for example, laparoscopic for ovarian drilling, and bariatric surgery if BMI more than 40 or if BMI more than 35, but there is comorbidity. This is very important. The last thing, which is very important and always come in the exam questions, it is good practice to recommend treatment with gestodine to induce a withdrawal bleed at least every 3 to 4 months. The long risk factor, as we know, as a metabolic syndrome, including obesity, hypertension, insulin resistance, and arteriogenic dyslipidemia, long-term consequence, which is cardiovascular, type 2 diabetes, individual hyperplasia and cancer, sleep apnea, physiological problem, and gynae risk, infertility. Thank you. Okay, just I have to add just 2 points. 1 minute. Actually, I don't have time to write it in the ovarian hyperstimulation part. Is that when you will report the case to the MRCOG UK, it is for any death related to ovarian hyperstimulation syndrome in UK must be reported to mother and baby, reducing risk through audit and confidential ignoring across UK, which is MRCOG UK. So any death, because this is always came in the EMQ question, that if there is any death from the ovarian hyperstimulation, go direct for report this case to MRCOG. Okay. Regarding if you have ovarian hyperstimulation,
severe cases, severe ovarian hyperstimulation.
Yeah, the severe.
Critical, but we have to report. No,
the severe. I think the severe not. I think not for the MRCOG. For the HIFA.
HIFA, yes,
if anyone
HIFA.
Yes. Can correct me. Yeah.
Yes, HIFA. Yes, severe and critical.
Yes, the death is for the MRCOG UK, but the HIFA, it is any incidence of ovarian hyperstimulation, especially the severe one, should be reported within how many working hour? Anyone know? Hello?
No,
3 days. Within 12 working hours, followed by a complete incidence report within 24 working hours. This is very, very important. So 12 working hours to report verbally, and followed by complete incidence form within 24 working hours of the incidents being identified. Okay?
Okay, shukran, Dr. Rasha. Thank you very much.
You are welcome. You are welcome. And I want to tell you, regarding the دقيقة. So you are welcome. Just I want to tell you regarding, I forget one point. Yeah, I want to ask you, anyone can tell me what is the mortality rate of the bariatric surgery for this? Anyone can tell me, because this is an important question.
No, we
the
don't have
percentage,
it.
you know?
For me,
Okay.
I don't have
So,
it.
0.1%
It is how much?
1%.
Yeah, exactly.
0.1 to 1%.
Excellent, Geetika. Yeah, excellent. It is 0.1 to 1.1%. It is very important. Okay. Let's go for the question. Is that what is the mortality rate? Okay, for the bariatric surgery. Okay. So who will go for EMQ1? Anyone can volunteer?
I will do it. A 36-year-old woman presents with secondary subfertility. Proximal tubal occlusion is noted on HSG.
Yeah. Yes.
Proximal tubal occlusion.
It's a tubal cannulation. It's a
tubal cannulation.
Yeah,
you mentioned
exactly.
in your slide.
As we mentioned today. Yes, exactly. Yes. Excellent. As we mentioned today, it is tubal cannulation for the proximal tubal occlusion. Excellent.
So when we will do salpingotomy?
Salpingectomy in case of hydrosalpinx.
Why not salpingotomy? Salpingotomy.
What salpingotomy?
Okay, thank you.
Why salpingotomy?
Actually, ma'am, I just wanted to ask one thing. Yeah, if they have given laparoscopy and diet test as an option, because the sensitivity of HSG is just 53%, I suppose. So if they have given laparoscopy and diet test as an option in EMQ, so should we choose that? Because the spasm can also cause false positive rate in HSG, proximal tubal occlusion. Or we should go for cannulation.
Before we mention that, before we tell we have EMQ, we solved it before the last time, that if there is a history of PID or ectopic or previous tubal surgery, we will go for lab and dye.
Happened.
Yeah.
There was a question.
Yeah.
Yes.
When we have it already.
So if there is any comorbidity along with it, so we will go for
with the
laparoscopy
tube,
and
you
dye
will go
test.
for lab and dye. Yeah.
And no history HSG.
Yeah. So we'll go for the next question, please. Complete. Who was answering?
Yeah, Rasha, I am here.
Vishnu,
a 37-year-old lady.
Yeah.
Yes. A 37-year-old lady with ASA, that is American Society. I am not sure.
Yeah.
Stage 4 endometriosis, diagnosed at laparoscopy, presents with primary infertility. Can you show the options, please?
Yeah.
37-year-old lady with stage 4 endometriosis, diagnosed at laparoscopy.
Excision of the endometrioma.
Yeah. No, stage 4 endometriosis.
Endometrioma is the stage 4.
No.
With severe adhesions.
So what you will do?
What about H? H, ablation excision of endometriosis.
As far as I remember, ma'am, that we do ablation excision only for stage 1 and stage 2. For early stage diseases, we are doing ablation and excision. But late stage disease, we are directly going for IVF and ICSI, I suppose.
IVF. Yes, IVF
Yeah.
ICSI we have to go. This is stage 4 endometriosis.
Natural cycle IVF.
Yeah. It's IVF actually, but I think here the option there is a wrong. I like this. I make it. I mean I transfer it, but I think it is IVF. IVF without, maybe with or without ICSI, according to the male factor. Okay.
Yeah, because it actually says that a late stage endometriosis shouldn't be treated for infertility.
Yeah, it will not increase the chance of yeah. Okay. It is clear now?
It is almost the soal.
No, Dr. Rasha, it is not clear for question 2. Can you explain it for us?
37 years old lady with American Society stage 4 endometriosis diagnosed at laparoscopy present with primary infertility. So he had stage 4 endometriosis. Okay. As per the NICE guideline said that for the stage 4 endometriosis, for the mild one endometriosis, the surgery will be benefit. Maybe it will increase the outcome of pregnancy. But for the stage 4, the surgery, it will not increase the chance of pregnancy, or means that the outcome of pregnancy. So better to go for IVF direct. Am I clear?
Okay. Yes, thank you.
Yeah. Okay,
Please
so
the previous
question 3
question I want.
Vishnu?
Pardon, Rasha.
The question.
Shall we go for third?
Yeah, as I said, yeah.
A young couple. Yes, a young couple where all investigations are normal, but the husband is HIV positive.
Yes. So.
Can you show?
IUI.
IUI.
You have to go
IUI? Yes, yes. Excellent. Excellent, Vishnu. Yeah.
If the viral load is less than 50
There are
copies,
50.
then we can go
50.
without sperm wash. Yes, madam.
Yeah.
Less than 50 without sperm wash.
Yeah.
Criteria.
Exactly.
It will be IUI without gonadotropin, yes, Dr. Rasha? Because there is option IUI with gonadotropin and IUI just
alone. Yeah, alone.
Yes.
Because there is no problem with her for that. Yeah.
Dr. Rasha, excuse me. Regarding question 2, the answer is IVF and XZ, plus or minus XZ?
Plus or minus XZ, yes.
Okay.
Better بعد I will correct بعدين, okay? But plus or minus XZ according to male factor, okay? Yeah. Who will solve with me? Who another volunteer?
Yes, doctor, I can.
Yeah. Yeah, sweetie. Actually, I found all of you, mashallah. Inshallah, you will do it. Inshallah, you will do it. Yeah. Very nice. Really, you have a good knowledge. mashallah.
يديك العافية يا دكتورة على الكلام الخبيث ده اديتيني رفعة معنوية.
لا إن شاء الله بإذن الله.
Number 5.
Yes. For question 4, yes.
Fourth question.
A 35-year-old woman presents with primary subfertility for 3 years, amenorrhea of 6 months, pelvic ultrasound and ECG suggest intrauterine adhesion.
Azar, please mute yourself.
Hysteroscopic adhesion.
What?
Can I see the option,
primary
please?
subfertility already 3 years.
Okay. So
Adherolysis.
Of 3 years and amenorrhea of 6 months. The pelvic scan show intrauterine adhesion. Yeah. I think this is the gift question. What is the answer?
H.
Yeah. Excellent. Yeah. Okay. So EMQ2, this is the option, and then this is the question.
Dr.
Yes.
Rasha, for the last question.
Yes.
Is this the answer H or another one?
It is H.
Yes, H.
Ablation, excision and adhesionolysis.
But she is not endometriosis. She had endometriosis.
Yeah. I know. But this is the only option that we can put it. Okay, adhesionolysis. Okay.
No.
Why operative hysteroscopy?
Why not operative hysteroscopy? Yes.
Because it's shown the intrauterine addition only, no. So it does need operative hysteroscopy to add.
It can be operative hysteroscopy or H, but the answer actually is H.
Ablation how can it be H? It's shown as endometriosis, no?
Please show the question again, doctor.
No, it's also done for adhesions.
Read the question.
Only intrauterine adhesions.
Yes.
Dr. Rasha,
So operative hysteroscopy. Operative hysteroscopy.
Yeah, it can be operative hysteroscopy, but if there is endometriosis, you can do this this one if it is mild.
Video goes for endometriosis. No?
Yeah.
Endometriosis.
It is more specific if you said F, but H also it can. Okay, because sometimes in the question in the RCOG, in the EMQ, you can found like this, and there is no operative hysteroscopy, so you can choose it at that time. Okay, not always can came like this. Okay.
Can you please confirm?
What is the final answer, doctor?
Both of them can be, but F, specific one is F, but H also can be. And the answer actually, as I found it, is H. The answer which I found is H.
Okay. Actually, I found also a question like this, but it was Asherman. Also, H was the answer. Ablation and excisional for
Yes,
Asherman and for
that's why I tell you.
any adhesions we can do this.
Adhesiolysis. Adhesiolysis is mentioned in A.
Adhenolysis. Yes.
Yeah.
Yes. So let's go for the next.
That adhesiolysis is not for intrauterine adhesions.
Yeah, so the next question, Sweetie?
Yes. An athlete
Please,
practicing...
other mute, please. Other to mute, please.
An athlete practicing intensely for the marathon presents with oligomenorrhea and primary subfertility. I think it's for taking steroids. So
what is the answer?
Maybe C is the answer.
Yes, because why? Can you explain why?
Yes, I can try. She is an athlete. Perhaps she takes steroids and it is causing hypogonadism. So can give her gonadotrophins.
Yeah, because the first thing is that what type of the WHO ovulatory failure? Which one?
Hypothalamic hypogonadism.
Type 1. Type 1.
Type 1.
Type 1. Yes. So we will give what? You will give what?
GnRH.
Yeah, GnRH with LH. SHH active should be given.
And,
yeah, so the answer is C.
and even pulsatile one also.
Yeah.
Pulsatile.
Pulsatile gonadotrophin.
Yes.
Okay, but here gonadotrophin with the answer here is C. Gonadotrophin. Okay.
Okay.
Second question, yeah.
A 38-year-old BMI of 32 presents in a secondary center with secondary subfertility and oligomenorrhea. Semen of her husband and tuber patency is normal. She is not eligible for IVF in the NHS and unable to afford privately. She has 6-month clomiphene at increasing dosage, but cycles are anovulatory. So in her case, perhaps she is having PCOS. So we can go for laparoscopic ovarian drilling because she has already died for 6 months.
No.
Why? Add metformin.
No.
Metformin.
This is metformin resistance.
I want the one who put the paper in the secret.
Taken
Who put the paper? The one who put the paper in the for this to explain the clomiphene resistant.
Because she is still anovulatory.
So,
in spite of using clomiphene for the last 6 months, it's not ovulating. So it indicates resistance.
Resistance.
And her BMI is 32. So next step would be laparoscopic ovarian drilling.
Yeah. And she is 38 years old. You see, time is less.
Yes, not laparoscopic ovarian drilling. If patient
no
ovarian drilling.
No GnRH.
No, it is IVF after 6 cycle of clomiphene.
IVF in case of failure, but if resistance is GnRH.
Yes.
Yeah. Actually, this question, okay.
IVF is considered in case of failure.
I think
there is there is failure and resistance.
She put the PCO talk.
Yeah, maybe.
Hala.
Yeah.
Yes. So, can you answer this question, Hala?
Yes, doctor. Because if patient she is PCO and she received clomiphene citrate for 6 months, we have to look if she is ovulatory or anovulatory. If it is ovulatory, it's
to get pregnant means that it is clomiphene failure to get pregnant. So we go that there is ovulation, so we go for IVF. If there is no pregnancy, we go for IVF. If it is anti-ovulatory, means it is resistant to get ovulation of this clomiphene. So go for ovarian drilling.
So we'll go for
ovarian drilling.
Ovarian drilling or gonadotropin therapy.
Actually, it's because also body mass index, she is obese. Drilling يعني for low body mass index. This case for GnRH.
Yes, I agree.
For gonadotropin therapy.
Load is better for lean patients with high LH. So gonadotrophins are better in this case.
Yeah, exactly. Who tell this? Because if they tell you that the ovarian drilling, I said in my last session, is that ovarian drilling
for lean patient.
For slim, for slim patient, and also for what?
High LH.
High LH. Hypersecretion of LH. Exactly. So this patient here, anovulatory, means that we will go for gonadotropin therapy.
Yes.
Okay. And when we want to define the clomiphene citrate, is that failure to ovulate rather than failure to conceive despite ovulation. Okay?
Yes.
This is the definition.
Yeah.
So the answer here
this is exactly definition of failure, yes. And if failure, then IVF. But if resistant, then GnRH.
Yeah.
Sorry, Doctor.
So here the answer is what?
What you do?
So the answer here is what? Where I go?
Bicycle GnRH.
I went. So the answer here what? Please tell me.
GnRH.
GnRH.
Dr. Rasha, excuse me, Dr. Rasha, can you mute the others and explain, please? I cannot understand this. I'm confusing, please. Mute all, then explain for us, please.
Yeah, explain. Yeah.
Okay, just 1 minute. Just let me talk. Because if I mute, because I'm entering from the other, I will mute myself. Just 1 minute.
Can everyone mute herself?
Yeah. Okay. Yes, everyone is talking. Okay. So, this question, just 1 minute. Yeah, the question is that a 38 years old with BMI of 32 present in a secondary center with a secondary subfertility and oligomenorrhea. Semen of her husband and her tubal patency tests are normal. She is not eligible for IVF in the NHS. So means that IVF will not be done for her. Okay, means that she try her 3 cycle or her 3 trial. Okay, are unable to offer privately. So if you read the questions carefully, you will know the answer. So IVF option will not for her not an option. She has 6 months of clomiphene of increasing dosage, but cycle are anovulatory. Means that it is clomiphene resistant. Okay, as per TOC, which is why not metformin? Metformin already she's resistant now. 6 months of clomiphene at increased dose. Okay, still anovulatory. Means that we will not try again by clomiphene. Khalas, finish. So what
can I say something, Dr. Rasha? Dr. Rasha, according to the guideline, no. If the patient is taking clomiphene for 6 months and then you find that the clomiphene is resistant and the body weight is more than 25, okay, then after that, either to offer her clomiphene plus metformin or gonadotropin. This is the second line, yeah, Victor. So for me, we will go for metformin because we already the patient.
But if you see also in the guideline written that the clomiphene will not give clomiphene more than 6 months. Here it can be given, but in the talk, just let me explain.
No, it is after 3 months. After 3 months, if the clomiphene no ovulation occurs, then you go for the clomiphene and metformin. Not after 6 months.
Let Doctor to finish, then you can tell everything you want, please?
Yeah, in the talk, this very clear in the talk. Okay, even for the definition of the clomiphene resistant, he said that if the patient, after 6 months, patient you give her clomiphene and still like this scenario, not ovulating, means that this is clomiphene resistant. You will go either for gonadotrophin therapy or ovarian drilling. Okay, but always in the NICE event, they said that this is from the talk, yeah. But even in the NICE, they said that you will not recommended to give clomiphene more than 6 months. Okay, because already the patient tried for 6 months. And what is that? He said that another clomiphene. Is clomiphene now resistant? What is the benefit from clomiphene again? Okay.
According to the guideline, it is very clear written. If the clomiphene resistant, then
my dear Nahla, I just posted. Just read it carefully by yourself.
Yeah,
You
read
will
it carefully,
understand.
please, in the
Okay.
top.
Just read it carefully. Yeah. I just posted to you here.
Okay,
very clear.
This is from talk article. I just copy and paste it. This is their words. Thank you.
Okay.
So you have two options.
Clear, Dr. Rasha. Yes, clear.
Yeah. So either you have gonadotrophin or ovarian drilling. Ovarian drilling, it is the mark or the clue in the question is that the patient have hypersecretion of LH and have a thin or lean BMI, body mass. Okay. So you will go for laparoscopic ovarian drilling. But this patient actually have 3 options: either IVF if more than 2 years, okay, or gonadotrophin or ovarian drilling. IVF already, maybe she tried 3 times, we don't know, or she's ineligible, maybe she had a baby, okay? So IVF, no. Gonadotrophin you can do for her. Ovarian drilling, laparoscopic, because BMI of 32. It is not lean BMI, body mass, I mean, okay? So that the best option for this patient is gonadotrophin.
Okay, I got it.
Thank you, Dr. Rasha. Thank you, clear.
Yeah. So question 3, who will go?
Sorry.
Sweetie, you complete? I don't know if you complete.
Sorry, Dr.
Sweetie,
Rasha. What is the answer?
Yes, I can go.
Yeah, you complete your 3, Sweetie?
No, 2, only 2.
Okay, you can go for the same.
Okay, thank you. A 30-year-old woman with a normal BMI presents to fertility clinic.
Just 1 minute. Yeah. Read.
With oligomenorrhea and following hormonal profile, luteal phase, progesterone, and ovulatory. So she is not having ovulation. LH 7, FSH 6, prolactin 2000, and the results are consistent on repeat testing. She is not on no medication. Thyroid function and testosterone level are normal. So prolactin level is high.
So you will go for
something with prolactinema.
So the answer is?
It's K, bromocriptine.
K. Yeah, exactly. It's bromocriptine and gabapentin. Yeah, you are right.
Thank you.
Okay, thank you, Sweetie. Thank you so much. Excellent. Who the other volunteer?
I will do Dr. Rasha.
Yeah.
A 30-year-old woman with type 2 diabetes and BMI of 32 presents with oligomenorrhea and anovulatory subfertility.
Yes.
So we have to tell her to reduce her weight because BMI is 32 and control her blood sugar.
Yeah, I want to tell you one point is that when you are, please other mute, when you solving EMQ, okay, just first thing, read the scenario well and just put by the pencil just the important point, because not to forget, because sometimes the scenario will be too much long. Okay, so just write, for example, type 2 diabetes, BMI 32. Okay, like this. because it will be easy for you. And immediately put in your mind what is the answer. Okay? Yeah. And then try to read, because maybe you will find your answer, but you may find another one which is better than your answer. Okay?
Yes. Yeah.
Yeah.
So options are where?
Yeah, I will tell you now. This is the option. So
and
now
only the metformin is the one written here.
Yeah, metformin. Exactly. Yeah, it is metformin. Why?
Metformin, yes.
Yeah. Why metformin?
Because type 2 diabetes, and she's BMI also raised and oligomenorrheic, so we will give her metformin. It will help on reducing the insulin resistance, also controlling her weight and diabetes also. So it will help her out.
Yeah, exactly. Okay. So, what she said? Why? What is not A? What is A? I don't know what is A. Sorry. Sorry. What was the A? Clomiphene?
Previous slide, Rasha.
Yeah, but
Fifth
yeah.
question.
Yeah, type 2 diabetes and a BMI of 32 present with oligomenorrhea and unregulated fertility. As you know, this metformin and loss weight, it will improve the fertility, the ovulation, as per the GTG guideline. So you will start first by the metformin, by the metformin, first. Okay? Because here patient is type 2 diabetes, means that the benefit for the insulin resistance is big with this. Okay? Yeah.
So you are saying that once we have controlled her diabetes, then we will go for fertility.
Yeah, everything will be normal after that.
Okay.
Even the ovulation.
Thank you.
Yeah. Thank you.
Okay.
So next.
What is the answer, Doctora? The metformin?
Yeah, the metformin. Yeah.
Yes. Okay.
Okay.
A same-sex couple with normal investigations presents to fertility clinic, try to conceive.
Yeah.
Okay.
IUI.
Yeah,
donor
exactly.
IUI, yes.
Yeah, IUI with donor sperm.
The donor sperm.
Yeah.
Donor
This is actually this same sex is very important. One of the spotting of the cases for the third part. Okay. So you will face two couple. You will came to you because one of the courses we attend in the UK is that same sex. Two couple came to me and they asked for baby. So IUI with donor sperm. Okay.
Yeah. Yes.
Next question. EMQ3. You can read.
23-year-old woman who is studying at university present to her GP with amenorrhea during the last 6 months. She has a body mass index of 15, but she thinks she's overweight and goes to the gym every day. Her urine pregnancy test is negative. A blood test reveals slightly low follicle stimulating hormone and luteinizing hormone level. So we will give her gonadotrophin because the hypogonadotrophic hypogonadism. Type 1 diabetes.
Hypothalamic cause.
Hypothalamic
cause.
No, what is the condition?
Anorexia nervosa.
Hypothalamic cause.
Please, other mute. Please, other mute.
Hypothalamic cause because she is not this one because she is exercising a lot. That's the reason hypothalamic cause I think for her going for her. Not anorexia nervosa. H.
It is actually anorexia nervosa. This patient. Am I right?
Yes, BMI is 15. Anorexia nervosa, but she thinks that she's overweight.
No, but
she thinks
she was
she's overweight.
exercising a lot. Okay.
She thinks. Okay, she thinks.
Yeah. Okay.
Yeah. So if you read it carefully, you will read it. You will solve it right. So just in the exam, read it carefully. And as I told you, if you write the just point in the beside the question, it will be better.
Yeah.
Okay, because the time management is very important in this exam. Okay.
Dr. Rasha, can you please explain how to differentiate between anorexia nervosa and hypothalamic cause?
The hypothalamic cause, for example, it is.
How will be the scenario in hypothalamic cause? Because this case I thought hypothalamic cause.
I think it is the same. You can choose both here in this question, but he won't hear a specific one. Always see the question was yani here the specific one is that anorexia nervosa. Okay. This is the specific one. I know it's hypothalamic cause, but he gave you
She thinks that she is overweight.
But it's the same. You can. I mean that anorexia, one of the hypothalamic cause, as we know.
Yes,
okay?
That's why he. Yes.
Yeah. So,
thank you.
The next.
Okay.
Who will?
I will read.
Yeah, to complete.
Shall I read, Doctor?
Yeah, you complete your question or still or what?
I think Sri finished.
Sri finished? Okay. Thank you, Shazia. You were Shazia? Thank you, Shazia.
Yes, thank you.
Thank you. Yes, other?
Shall I read,
Volunteer?
Doctor? Yeah, Dr. Nikki. A 30-year-old woman presents to her GP with amenorrhea lasting a year. She gives a history of an intraductal carcinoma of the breast 18 months previously. Subsequently, she received 3 cycles of chemotherapy, followed by a left-sided mastectomy. 4 weeks after that, she received radiotherapy to the left breast and axilla. She has 1 child and wants to conceive. IVF?
Sorry, just I want to bring to you the, yeah, this is the option. Yeah. So, what is your answer?
She's a 30-year-old
premature menopause. Answer N.
Who said that? Just let who was answering, please?
Dr. Nikki, Doctor, this is
Nikki, what is your answer, Nikki?
N, premature menopause.
Excellent.
Radiotherapy induced premature menopause.
Yeah, exactly. The chemotherapy, it is what used in the management of this breast cancer, which can affect the ovary and cause this premature menopause. Excellent, Nikki.
Thank you, Doctor.
Question 3.
A 20-year-old woman is referred to the gynecology clinic having had amenorrhea for the past 6 months and a negative pregnancy test. She has recently noticed an increased growth of hair on the face, chin, and chest with clitoromegaly. Her blood test results show very high levels of 17-hydroxyprogesterone. It goes in favor of CAH or adrenal tumor.
Congenital adrenal hyperplasia.
CAH or adrenal tumors, we have to look. Options, please show the options, Doctor.
So, yeah, I show it now.
Late CH. Late onset CH.
Late onset, excellent. So just one can tell
late onset congenital adrenal hyperplasia. L.
Hyperplasia. Yeah. Excellent. This one. So just I want to tell you. Can you tell me, Nikki, regarding
adenoma? Sorry, why not adrenal carcinoma?
Adrenal carcinoma?
Yeah, why not adrenal carcinoma?
This actually, she had a manifestation of late onset congenital adrenal hyperplasia, because and for the adrenal carcinoma we said that there is a DHEA high, very high. Okay, here the high level of 17-hydroxyprogesterone, and there is acromegaly and RH and amenorrhea. All this goes with adrenal hyperplasia. Okay.
Okay, doctor.
Because if there is DHEA high, this means that it will go with adrenal carcinoma. Just I want to ask you how to differentiate between late onset congenital hyperplasia and the non-classical one. Anyone know?
Classical one, at birth it will manifest.
Hello.
Early onset congenital hyperplasia. Classical is early onset
Classical.
Classical
one can have even normal 17-hydroxyprogesterone with testosterone of less than 5 in case of heterozygous classical CAH.
Yeah. And what else? Exactly.
Ambiguous genitalia.
Yeah, and the classical always present at birth. Okay, early childhood and even sometimes in late childhood, but the late is usually manifest later. Okay.
Please repeat, doctor.
The classical one always or most likely present at birth, early childhood. Okay.
Okay, doctor.
The non-classical
Okay,
is usually in the adolescence or maybe later in women.
Yes, doctor. Thank you.
Okay.
I'm done with 3 questions, doctor. Thank you.
Yeah. Okay. Thank you. Who will answer the next?
May I read?
Yeah, you can read, of course. Who is me?
I'm Mariam.
Mariam.
Okay,
Welcome.
Thank you. A 25-year-old woman presents through her GP with a history of amenorrhea for the last 6 months. She's an athlete and has recently participated in the Olympics. Her serum FSH and LH levels are low. Normal. Her serum FSH and LH levels are normal.
So?
Hypothalamic cause, it's a functional.
Functional.
Yes, it is hypothalamic, exactly. Due to, in this case?
Stress.
Yeah.
She participated in
Stress-induced
Athlete
hypothalamic
means that excessive exercise.
But
Yeah.
FSH and LH are normal. How it could
can
be
be
hypothalamic?
It can
Okay.
be. It can be.
Could
Just
be
with
normal
hypothalamic
or low.
cause. Yeah, normal or low.
Yes.
Exactly. Okay, next.
Change the slide.
Question 5. Is it clear, the screen?
Yes, doctor. Thank you.
Can you who will
Okay.
Can I?
Yeah, question 5, please, fast, because we want to finish.
A 20 years old woman present to her GP with facial hirsutism. An
Please, other
irregular
mute, please.
for the
Yes,
past year. She
Yeah.
has recently put on weight and her BMI is 28. I think BCO.
Cushing-White syndrome?
PCO?
This is facial hirsutism, 20 years, irregular period, and recently put on weight, and her body BMI is 28. This is most likely PCO.
PCO.
Yes.
Please give the options, doctor.
Yeah, I will show you the
Please
answer.
options.
Yeah, I will show you just 1 minute. Please the option.
PCOD M.
M.
Why
Yeah,
not
M.
Cushing's disease and Cushing's syndrome? What is the difference between disease and syndrome, doctor?
What is the Cushing? What is the manifestation clinical feature of Cushing?
Yeah, doctor. Disease and syndrome, both are there.
Yeah, but the Cushing, there is another, I think there is a specific, when he said to you, central obesity, and there is, I think, yeah, there is specific features in this.
With diabetes, hypertension, abdominal striae, central obesity.
All these features for Cushing. Yeah, hypertension sometimes.
Syndrome.
Yeah,
Hypertension,
just see the
diabetes.
facial, yeah. I mean the clinical features, okay?
Okay, doctor, thank you.
Actually, each question in the exam, there is a clue. So just see the most likely clue or the thing which goes with the condition, okay?
Okay.
20 years irregular cycles.
So EMQ4. Thank you. Who will answer this?
Shall I answer, Rasha?
Yeah.
A 30-year-old woman and her partner present to the subfertility clinic and they're anxious to conceive. They have been trying for a pregnancy for the past 2 years since now. The woman has regular cycles with normal BMI and no prior medical illness. Semen analysis shows a volume of 2 ml with a count of 4 million and 5% normal forms, 35% progressive motility. This semen analysis is abnormal, being count is less.
Yes. So
count is less than 15. It is almost severe oligospermia with asthenozoospermia.
So what we will go to do?
Semen analysis.
Repeat semen analysis.
Yes, repeat.
We will repeat semen analysis immediately.
Yeah. If it is less than 5 as per the book, you will repeat it immediately. If it is more than 5, you will after 3 months. Okay?
Yes.
Okay.
رشا معلش السيفير اوليغوسبيرميا منكم سيفير اوليغو
less than 5
from how much? Less than
5 million. Yeah.
Thank you.
So how do you will be the next you will answer, you and Najwa. Yes, complete.
Rasha?
Yes, you complete, Vishnu. The next question.
Okay. 27-year-old woman presents to the fertility clinic with secondary subfertility. She has a 7-year-old child born of normal conception and had a normal delivery. She has ever used only male condom for contraception. Her cycles have been regular until a year ago. She gets very slight bleeding and has not had a period for 3 months. She complains of vague headache and difficulty in looking out of the corner of both her eyes. Urinary pregnancy test negative in the clinic today. She has some
pituitary adenoma.
Some visual field defect she has with amenorrhea. This is second amenorrhea due to hyperprolactinemia. So I would like to see the options. Maybe prolactinoma, serum prolactin.
Yeah, exactly.
I would like to.
What it cause? It will cause bitemporal hemanopia plus headache, as in
bitemporal
this. Yeah.
Yes.
Okay, and headache. This is most feature of this. Okay. So the next.
A 32-year-old woman presents to the fertility clinic with primary subfertility. Her periods are regular and her husband's semen analysis is reported to be normal. She undergoes a HSG which shows filling of the uterine cavity but no further progression of the dye beyond the both cornua. So there is a bilateral tubal block diagnosed at HSG.
So the answer is?
Please show the options, doctor.
Just 1 minute.
Options, please.
Yeah.
So bilateral tubal block.
Yeah, so it will be
secondary infertility.
The answer is I think here it is not written. No, I think here
B,
it is not written.
hysterosalpingogram.
Actually, HSD is already done.
Already done.
So I would
No, I think here there is one answer not written. I think the answer is not written. Sorry.
Laparoscopic diet test should be the answer.
Yeah. Exactly. Maybe I forget to write it. Sorry. I will write it later. But yeah, it is laparoscopic
Your
assessment. The
teaching
answer
has made us to answer directly. Your teaching is helping us to answer directly without options, doctor. Thank you so much.
Exactly.
Very true.
The way to answer.
Thank God we are blessed to have you.
What is the option?
Very
what is the
No, the option actually not written. Who's asking? Yeah, A, B, C, D. The option D not written, which is a laparoscopic assessment. Okay, in this area, I will write it. Okay, I will write it, inshallah.
Can you explain, Doctora?
Yeah, just 1 minute. Just 1 minute. Where is the question? Yeah, a 32 years old woman presents to the fertility clinic with primary subfertility. Her period are regular and her husband's semen analysis is reported to be normal. She undergo hysterosalpingogram, means that the first step is done, okay, which show filling of the uterine cavity, but no further progression of the dye beyond both corners. Means that there is a tubal problem, okay? There is a tubal problem. Maybe there is previous PID. She had a previous, for example, pelvic inflammatory disease lead to tubal block, okay? So at that time you did, because patient maybe she didn't have a history of PID. If she gave you a history from the start, you will not go for hysterosalpingogram. But here the patient maybe she didn't give a history of PID, okay, or any ectopic pregnancy before, or there is or any surgical in her tube. So surgery in her tube. So here the option is that after the hysterosalpingogram, and here more obvious that there is the dye not go beyond both cornea, means that there is tubal block. So we'll go for laparoscopic assessment, lab and dye means, and at that time maybe you will treat as well for diagnostic and treatment, okay?
Please, I want to ask a question, please. There is a top article about tubal testing. They said that the proximal tubal blockage can be assessed by hysteroscopy and tubal cannulation. What do you think?
Yeah, this is our answer before. We have the first question.
Hysteroscopic,
first question.
not laparoscopic.
Hysteroscopic, yeah, but here there is a tubal problem, as per NICE. Here there is a tubal problem. Yeah, if you diagnose it, okay, خلاص.
I mean that proximal tubal blockage at the cornea. They mentioned that hysteroscopy and tubal cannulation from the inside the uterus is preferable to laparoscopy from outside an assessment.
Yeah, but here
I tell something.
Okay, you tell.
Sorry to interrupt. So in this case, there is a tubal block which is diagnosed or confirmed in HSG, but it could be false positive, right? So under general anesthesia, and this is a case of secondary primary infertility. So under general anesthesia, sometimes the tube can open up. So automatically the dye test will be positive. So we go for laparoscopy whenever the HSG is shows tubal block.
Yeah, and the second thing which I mentioned, the second thing which I want to mention is that it is clear in the NICE guideline, not the talk. NICE guideline. If there is any tubal problem, you will go for laparoscopic immediately. Okay? Lab and dye immediately. As per NICE, not talk. Talk, this is another scenario, but you will go direct, always go with NICE.
Okay.
The last question, I think, in this one.
A 30-year-old man presents to the fertility clinic with his partner to discuss about starting a family. He admits to be HIV positive and is very compliant with his medications and is under follow-up with the local sexual health service team. His viral load is found to be 30 copies per ml recently. The woman is 26-year-old and has regular cycles and has had a child in her previous relationship.
Okay. So what is the information that you pick up from this?
He is HIV positive with viral load less than 50, and her female factor is normal because she has given a birth to the child previously.
Semen analysis.
Yeah.
Yes.
So the answer is, just 1 minute.
They presented to the fertility clinic.
Yeah. So the answer?
We need to repeat semen analysis.
Yeah.
Because
exactly.
female factor is normal.
Excellent.
Yes.
Yeah. Excellent. You are right. Okay. So I think
why,
it's the same.
because female factor what?
Normal. Female factor normal.
Why you choose
Dr.
semen?
Rasha, what was the answer of question number 3? Please, can you repeat?
3 is laparoscopic assessment. Okay. So just 1 minute. So now we finish this. Actually, I include this in this session, this PowerPoint. But I have my file, which is we solve I think 20 questions on it. Just to
Dr. Rasha, excuse me, can you repeat the last question, please? The
last question.
I want the scenario. Yes, I want the scenario.
Yeah,
please.
this you can read it, Najwa.
Okay. 30 years old man present to the fertility clinic with his partner to discuss about yes, starting a family. He admits to being HIV positive and is very compliant with his medications. And is under follow-up with local sexual health service team. His viral load is found to be 30 copies per ml recently. The woman is 26 years old and has a regular cycle and has had a child in her previous relationship. It's okay, yes, now.
So now
the next step,
there is no
yes.
clue about the semen analysis. So we'll go for the semen analysis. Okay?
Yes, because it's asking for the investigation, the head of the question. Yes, okay.
Yeah. Okay.
But if Dr. Rasha, if it's for management, if they ask for the treatment, so it's IUI for this case. If the husband is okay like this, yeah.
Yes.
Okay.
Yes. Okay.
Okay. Thank you.
Thank you.
And Dr. Rasha, if it is less than 50,
why
then
IUI? Why IUI
timed,
less copies?
we will go timed intercourse. It's like because it's less than 50, so no IUI in this
exactly,
case.
Yes.
Yeah, but if the patient, for example, not guarantee because there is a risk, even if less than 50, you can consider IUI.
So, Dr. Rasha, IUI if the copy is more than 50?
Yes.
If more than 50, but sometimes if the patient, for example, after you, because even if less than 50, no guarantee that there will not be risk. It is negligible, but maybe there is a risk. And maybe the patient tell you, no, I don't want any risk. At that time, you can consider IUI.
Okay. Yes.
Okay. Okay, so we will go for just for this one. Just give me 2 minutes to put the other file. Just 1 minute. 2 minutes, I mean.
ما عندك أي مشكلة معاكي.
Okay.
Thank you, my dear. I hope it benefit really, wallahi. I try to catch the important.
Dr. Rasha, you will give us question about also same topic, same. You will give us your file now question, same topic, the fertility.
Yeah, infertility, just infertility. Yeah.
Because we need more question really for this topic.
Yeah, I know. That's why I put because always this infertility, not an easy. I think.
Yeah. Yes.
Need to have a practice on it. Just 1 minute.
Practice for question, not for the reading the guidelines.
Yeah. That's why I try to make it very.
Dr. Rasha.
Yes.
Can you please present this type of concise class on contraception, if possible?
Okay, I think like this. So just if you can give me 5 minutes, sorry, just 5 minutes, and we'll start. Okay.
No problem, dear. You are waiting.
Okay.
Thank you.
Thank you.
خلصت جواب؟
Okay, let's start. So I think we complete till question 24. Next is 25. This is EMQ. Who will start? Suhad? Or anybody? Fatma, Suhair, anybody in the...
Shall I do, Rasha?
Yes.
A 34-year-old woman with BMI of 23 has been trying to conceive for the past 3 years. Her partner's semen analysis is normal. She has had a scan done which suggested PCO. Her serum progesterone on day 21 is 6 nanogram per deciliter. Her FSH is 3, LH is 5. She has been on clomiphene citrate for the past 6 months. A subsequent scan and hormonal test had confirmed ovulation.
So, what is your answer?
Everything is normal. Yeah?
So means that
laparoscopic ovarian drilling.
No, it is a CC failure. Need gonadotrophin.
All the hormonal profile is normal, but there is a CC.
Hormonal profile is normal here. Am I right?
Yes, hormonal profile is normal. There is
that she's ovulating.
She has ovulated out. It is CC failure.
Yes, gonadotrophin.
CC failure.
Okay, let's read the scenario with each other. A 34 years
At
old
one
woman.
point, ma'am, they are saying that serum progesterone on day 21 is 6 nanogram. So 6 nanogram is less. And then
Means
they
that
are saying that, yeah, but then they are saying that subsequent scan, it confirms ovulation. So it's a contradictory system.
Means that clomiphene is okay. Is she benefit from this clomiphene citrate? Means that you will not stop clomiphene citrate because the patient, she responds to clomiphene citrate. Okay, so we will continue clomiphene citrate.
So we will add metformin,
metformin.
L.
Why metformin?
But she has taken clomiphene for 6 months.
Because she's PCO
She's already taken for 6 months.
So now the patient, okay, now the patient is ovulating, okay, and nothing. Investigation are normal, everything is fine, and still not conceived.
Then, Doctora, this is IVF because this is failure. She failure to conceive, not metformin failure. That's mean IVF.
No, we can
actually,
induce the gonadotrophins, no?
Actually, they said in this question, the answer is clomiphene citrate stimulated intrauterine insemination. Okay, see the answer.
Sorry, Doctora, but you said
but I think she tried to conceive for the last 3 years.
No, analysis is not.
Can we use clomiphene citrate more than 6 months?
Actually, here this is the answer in this question. But for us, I think we will not. Yeah, but I want to tell you is that this patient, she is responding for clomiphene citrate. Okay, this means that she's ovulating. Just I think you will type this as IUI.
Dr. Rasha, please.
But according to TOG article, they said if she's responding and there is ovulation, that means failure to conceive.
I know, my
that's
dear.
mean IVF.
Yeah, I know, but
now I'm very confused.
Yeah, I know it's IVF, but you will start by IUI first.
Sorry, but she is trying since 3 years. Also note this, she's trying since 3 years, so why not IVF?
Dr. Rasha, it's clearly written in the TOG article that if she did not conceive within 6 months of clomiphene citrate and she's ovulating, directly they said
for IVF immediately. Okay, but before this talk, it was IUI first, then IVF.
Yes.
Okay, so now it means that as per the last one, means that it is still they are encouraging not to go for more than 6 months, means that it will be IVF. Is it clear?
Thank you. Now clear. Thank you.
So this is a really I put the difficult question actually because I want discussion.
So the final answer is C, doctor.
Yeah, the final answer here, please. According to the previous before the talk, it was IUI, clomiphene IUI. Okay, but nowadays because of this talk, okay, you will go for IVF B. So the answer is B. Okay.
Okay. Yes. Okay.
Yeah. The next question. Yeah, it is B. The next question, to go fast, please, because we have more than 50 questions remaining. We want to finish. Sorry.
A 29-year-old woman with BMI of 32 has been trying to conceive for the past 4 years. Her partner semen analysis is normal. She has had a scan done which suggested PCO. Serum progesterone on day 21 is 2 nanograms. FSH is 3 and LH is 5. She had been on clomiphene for 6 months, but she failed to ovulate.
So
there is clomiphene resistance.
And what else? There is important
laparoscopic ovarian drilling.
Why
BMI 32?
BMI 32.
Gonadotrophine.
Yeah, we said this before. Just concentrate. Yes. Okay. It is actually it will be clomiphene plus metformin because BMI is 32. Okay. You will not go for ovarian drilling. We said that ovarian drilling is for the lean body mass. Okay. And also if you have a hypersecretion of LH.
Yes.
Who said ovarian drilling? Who said ovarian drilling?
I said Dr. Nikki.
Who are you? Nikki? Okay. So Nikki, please answer the last question. 27.
Dr. Rasha, now the answer is gonadotropin.
Why not clomiphene plus
because she finished 6 months and failure. That's been gonadotrophine, according also to the same TOG article.
A 30-year-old with primary infertility and PCOS diagnosed over 3 years.
Here, this question actually will go with the metformin because BMI of 32. Maybe the best answer is metformin alone. Okay.
Dr. Rasha, this is same question before we answered gonadotropin.
But she finished, Doctora.
The other one finished also
yes,
6 months.
Sorry.
She finished 6 months.
Gonadotropin, so gonadotropin.
She finished 6 months means that resistance,
months, yes.
so that gonadotropin or what? Ovarian drilling. Ovarian drilling not here because BMI is 30.
Body mass index, yes.
Ovarian drilling is here also there, doctor.
Body mass index is the contraindication.
32 here. Sorry, because I'm not in the exam. I'm not going to the exam. Because better to concentrate.
Okay, it's okay, Dr. Rasha.
Doctor,
Yeah.
Excuse me.
Yeah, better to clarify. Thank you, Ridwan.
In previous question, we have seen a 38 years old with 32 BMI with clomiphene citrate for 6 months with anovulatory cycles. You have said that answer is ovarian drilling for that.
Which question? Where?
Previous slide in the before when you have done the class followed by questions.
No, we didn't say ovarian drilling at all. No, we didn't say ovarian drilling. Any answer until now? The question for the ovarian drilling not come.
No. Yes.
Dr.
No
Rasha,
question
Dr.
had
Rasha, one answer drilling, but we correct this one according to the BMI. Yes.
Yeah, we told that because BMI is high, we will not go for ovarian drilling. Exactly.
Okay.
Yes.
Yeah.
Dr.
Just
Rasha,
concentrate, please.
the
Just
same
don't waste
question.
time and yeah.
The question before you answered that it was gonadotropins, and now you are answering metformins, and it's a
No. Because I told you now, not metformin. I corrected it now. I said that it will be gonadotropin. I corrected gonadotropin and metformin maybe because BMI is 32 here. Okay.
It's okay. Answer K.
This patient will benefit. Yeah. This patient will benefit from the metformin because BMI is 32.
Yes.
So what is the
if you go for the exact answer for this question, which I found it is L, clomiphene and metformin. But according to the new talk, as it mentioned, the clomiphene resistant, you will go for gonadotropin. Okay, so we will go for gonadotropin, and because of the BMI is 32, we will go for the metformin also. Okay.
Okay, doctor.
Okay. Next question. I want Nikki to answer the 27.
A 30-year-old with primary infertility and PCOS diagnosed over 3 years ago attends the fertility clinic. She has a BMI of 25 and is keen to try ovulation induction, though she has failed to ovulate after 5 cycles of clomiphene citrate with persistent hypersecretion of LH.
So here's the answer.
Ovarian drilling.
Laparoscopy.
I want Nikki to answer.
Sorry.
Then but it is laparoscopic ovarian drilling. Normal BMI.
And hypersecretion of LH.
Hypersecretion of LH. Thank you, doctor. Okay, doctor.
Okay. Next question. Najwa or Fatma?
Yes.
Najwa, yeah.
Hello, Dr. Rasha.
Yes, doctor. Yes. 28 after
But they said
ejaculation.
to try ovulation induction. She's keen. She's keen to try ovulation induction. I said the question said the woman is keen to try ovulation induction.
You mean question 27?
Yes. They said she's keen to try ovulation induction, though she has failed to ovulate after 5 cycles of clomiphene citrate. Is it not to add clomiphene for me? Because she's keen, and you have tried clomid alone.
Yeah, she's keen, but still she's failed for after 5 cycles, and there is hypersecretion of LH. This is clearly that if there is hypersecretion of LH and BMI is normal, you will go for ovarian drilling. This is very clear. Okay? You will go direct for ovarian drilling.
Okay. Thank you.
Yeah, thank you. Yes, Najwa?
After ejaculation, how long can the sperm survive inside the female genital tract? This 5 days, I think. 5 days? 5 by 24.
7 days.
How many hours?
E?
168
hours.
168 hours, 7 days.
168. Excellent, Najwa. Yeah.
168.
Yeah.
168.
Yeah. Because the sperm can survive for up to 7 days. Okay? Means that 168 hours. Okay. Next, Najwa.
After ovulation, how long does?
The answer is E. E.
Okay. After ovulation, how long does an egg usually survive inside the female body? 12 hours.
24 hours.
24 hours.
Yeah, excellent. It is 24 hours. Yeah, exactly. Yeah. Next.
35 years old woman. 35 years old woman with regular period until 3 months previously suddenly developed amenorrhea. Her hormone level show increase FSH level of 16 with reduced estradiol and normal prolactin level. Her BMI is 20 and she is athletic. There is similar history of amenorrhea in her sister who is 38 years of age, which is the most likely diagnosis.
Here's the clue is the history of the amenorrhea in her sister.
Premature ovarian failure.
Premature ovarian failure.
Leave the one who is talking.
Premature ovarian failure. Yeah.
Yeah, premature ovarian failure. This is the correct answer. Excellent. This one actually it is amenorrhea with persistent estrogen deficiency and elevated LH. Okay, elevated LH level before the age of 40 years. Actually, it affects
and also family history also.
Yeah, maybe familial, and it is 1% of the woman.
Here they mentioned that she is athletics to confuse us between hypogonadism.
Exactly.
But because it's normal prolactin level that we can include this one.
Yeah, exactly. There's emphasis of 16 and reduced estradiol and normal prolactin, but the clue here and the mark is that she has a similar history of amenorrhea in her sister who is 38 years old. So it means that it is a premature ovarian failure. Okay. Okay. Thank you, Najwa.
Okay, welcome, Doctor.
So okay, others? Anyone?
I can read, Doctor.
Yes.
Woman present with 2 years history of secondary subfertility, having had 2 miscarriages over a course of 8 months with her partner of 6 years. An ultrasound scan reveals an enlarged uterus with multiple fibroids, and HSG last year confirmed patent tubes. The couple are keen to start fertility treatment and the semen analysis is normal. What is the most appropriate initial assessment prior to fertility treatment?
Yes.
Okay.
Multiple, large.
Copy to exclude.
Is it here?
Yeah, exclude cavity compromised by the fibroid before treatment.
Before starting the treatment of IVF, yeah, to make sure, because you want to make sure that everything is fine, so that especially the submucous, you need to be excluded to treat and to because it can interfere with the pregnancy. Okay.
Yeah.
So hysteroscopy to exclude cavity compromise by the fibroid before treatment.
Okay.
Next.
For each scenario posted below, choose the single most appropriate answer. The given answer may be used once, more than once, or not at all. Infertile couple, man was healthy woman with PCOS with an ovulation induced with clomid 50 mg. Estrogen level was high, follicle 20 mm, but progesterone on day 23 of 26 cycle show no ovulation.
100 milligram clomid.
So
increase the dose. Increase the dose of clomid.
Yeah,
B.
We will increase
100
the dose.
milligrams.
So B. Yeah.
100.
B. Yeah, 100. Yeah, exactly.
Okay.
Okay, next.
Infertility for 2 years.
Excuse me, I have a doubt.
Excuse me?
I have a doubt. Hello. She had a follicle size of 20 mm. She's not ovulated. Okay. CC50 with the timed HCG is option.
What you want to answer? I didn't understand. I get you.
Clomiphene 50 with timed HCG for trigger.
Yeah, but estrogen level was high and follicle 20, but progesterone is still not ovulation.
That's why. Okay. Okay.
No ovulation means that we will go to increase the dose.
Okay.
You get it?
Yeah, I got it.
But the follicles are of normal, like 20. So if we only trigger the ovulation by timed HCG, it will give the result.
Yeah, it can be either 100 plus time HCG, or it can be. But I remember this question because I think it came in our exam. It was time HCG. I think they wrote it, but it was not there in the exam. It's just chromate 100 milligram OD was the answer. Time HCG was not there before. I don't know who put the question. Okay?
Now the C may be the answer no, because she developed adequate size. Only she need a trigger to release the ovulation.
But still no ovulation. No ovulation.
Also, if we give more clomiphene and the size of follicles is 20, we will cause ovarian hyperstimulation.
Rasha, she developed a follicle of adequate size. She only not ovulated. If you're giving the dose, it will promote more follicle development only. No, it's not going to help for ovulation.
But Doctora, you need
it will cause
you need the progesterone to be adequate as well.
Yes.
Yeah, that's why I'm telling you the timed HCG will help for ovulation. No.
But we are not searching
not for ovulation.
We are searching for ovulation.
Yeah. Anna, for me, I think the answer here is B, 100, just to give chromate, because follicle already 20. I don't know who said that it should be C. Why it should be C? Anyone can tell me?
That's mean, yeah, Dr. Rasha, she means that the follicle not ruptured. She helped to this rupture follicle. Maybe she mean like
this is you mean this is for the rupture? Yeah, if this is for the rupture, because they said that it is HCG for ovulation. I want to clarify, is that HCG not for ovulation? Okay.
No, the answer they mentioned the timed HCG. No, that's why I'm telling for rupture only we need HCG, not clomid. No.
Yeah. Clomid is for ovulation, and HCG for rupture the follicle.
Yeah, that's why she developed a follicle. She need a rupture to get ovulation. No.
Yeah, but here, Anna, as I understand this question, it is not mentioned exactly if this the time now is it for rupturing the follicle or not. That's why we choose clomid 100 OD. But if said to you that it is the time for the rupture, you will go for clomid 100 plus time HCG.
Okay.
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 It's D, the answer.
See, if we mention to you that this is the time for the follicle rupture, it is which is around 24, I think, 36 of ovulation. This time. Okay, the time of HCG to give HCG to rupture the follicle. Okay. Next question.
26, the cycle 26. So the answer D, Doctora, or what?
The answer here, because as I told you, answer is B, because not mention the time of the HCG, means that he didn't tell you that she is now, for example, on day, for example, or after 24 to 36, within around this time for the ovulation. Means that
Dr. Rasha, but D option. I think it's more reasonable. We increase clomid and also
I
time
understand
HCG.
you, my dear. It is more reasonable if there is said to you that exactly the time of the ovulation, or the time of around the ovulation. But here just said to you that it has 50, try 50 and was not ovulating.
Okay.
It can be B, it can be D if there is mentioned to you that the patient now, for example, we start for her this 100 milligram. Okay, and now she is, for example, within 24 to 36 hour of ovulation. At that time, you can use this chromate 100 plus time HCG.
Okay, clear. Thank you.
Okay. 33. But here, I think here in this question, he wants a general idea. What you will do, you will increase the dose to 100. Okay. Okay. Next question.
Dr. Rasha, what is the answer of 34?
34 is B.
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 Still
because he wants the concept that what you will do, you will increase the dose, or what you will do, you will increase the dose. But if he tell you that now we will increase the dose, and now the time of ovulation, within the time of ovulation, at that time you will set that clomid plus time HCG.
Okay, this is for question number 32.
Yes, 32. Let's go for 33.
Infertility for 2 years. All investigations were normal except women with BCO with an ovulation evident by progesterone level. A. Clomid 50 milligram OD. We will start by this dose.
Yes, yes, exactly. Yeah, A. Okay.
Okay, thank you, Doctor.
Yeah, 34.
Excuse me, 32 answer is B or C?
B or C or what? B. Because you will increase the dose. It is B or D, okay? According to the scenario. But here it is B.
هي خلصينا.
Next question. Next question.
Infertility 3 years
قالت يلا خلصينا دي تجاوب.
سارة، اسمها سارة.
جاوب يا سارة. ما دام انت الوقت بتاعك very precious. I know. Answer.
Infertility 3 years, all normal. Women with PCO received 6 cycles of clomiphene citrate. By day 23 out of 26 cycle, progesterone range between 32 to 67. That means she ovulated. Infertility duration 3 years, but she ovulated.
Yes. So the answer?
She received 6 cycles of clomiphene already.
Yeah, so the answer what?
IVF?
Yeah, exactly.
IUI?
Excellent.
IVF?
IVF.
Why not
3
IUI?
years. No, IVF 3 years now. Fertility 3 years.
3 years. 3 years. And clomiphene failure.
Dr. Rasha, in this case, why we are not going for ovarian drilling or GnRH, gonadotropins? Because it seems there is resistance to clomiphene.
Ovulating.
It is not resistant.
Now
it is
this patient
failure.
ovulating. You'll go for IVF direct. Yeah.
Okay.
She's trying for 3 years, yeah. Yeah.
Okay.
So next.
You can't see the next question. Cystic fibrosis, both partners carrier, undergone IVF, 12 embryo. How many will be affected?
Yeah.
Cystic fibrosis is autosomal recessive disorder.
Yeah, exactly.
Both partners carrier.
So 1/4 will be
One will be affected.
1/4
2
will
babies.
be affected.
So 1/4 in partners carrier. Okay.
Okay.
3 will be affected.
So the answer is
4. C 4.
3.
It is
Answer C.
It is B. The answer is B.
B.
Yeah.
B. 12 by 4.
Yeah, because 12 by 4 is 3.
1:4.
1 to 4, yeah, 25%. So 12 by 4, 12 over 4 is 3. Okay?
Yes.
It's a common question.
Again, Dr. Rasha, calculation. Yes, we know this is 25.
Okay, so Marissa.
Yeah.
Can you show that question again, please?
Yes,
yeah,
please.
Sorry. Okay. Yes, this one.
3 diseased and 3 they don't have anything, and 6 career.
So
this is Dr. Rasha, please again the numbers, but we know, but the calculation by the percentage 25 will be affected.
Yeah, 1 in 4. So this means that we have 12 as 12 embryo. Okay, 12 embryo.
12 embryo. I didn't see. Yes.
Yeah, 12 embryo by 4. Okay, equals 3.
Okay.
So it will be 3. Means answer is B. Okay. Next.
Okay.
A 31-year-old woman presents with 1 year of primary subfertility. Her partner has a normal semen analysis and she has regular menstrual cycles. Although she suffers from severe dysmenorrhea and menorrhagia, an ultrasound shows 4 centimeters endometriotic cyst on left ovary with a normal uterus. What is the most appropriate form of tube testing for this condition? Laparoscopy. Laparoscopy, wherein we can do even ovarian laparoscopy.
Diagnostic or laparoscopy? Yeah.
Yes.
Yeah.
We can combine with the
So the answer is diagnostic laparoscopy. Okay.
Yes,
doctor.
Because it can treat the endometrioma. Why we didn't choose HyCoSy? Because it will treat this endometrioma also. Okay.
Yes.
Next question.
The following statement regarding varicocele is true. It occurs 10 to 15% of male population and 25% of those with abnormal semen analysis. I think this is the correct answer.
Yeah,
large varicoceles.
Yeah,
it's the correct answer.
Yeah, this is
25% with abnormal.
Yeah,
population, it is 10 to 15%.
Yeah, exactly. Okay, so the next answer, the next question, another volunteer.
Thank you. Dr. Rasha, again, repeat this A again.
A is that it can occur this varicocele, which is the distension of the distended vein, okay, at the area of the scrotum. It occurs in 10 to 15 of the male.
Yes.
Okay, and it can cause 25% of the abnormal semen analysis.
Okay.
So next. You said, doctor, why not HyCoSy? HyCoSy was the answer.
Yeah, HyCoSy because you cannot manage this endometrioma. Okay, by this diagnostic laparoscopy, you will treat even. Okay.
Okay.
48. Who is volunteer?
Varicocele with abnormal semen is seen in 25%. Varicocele with normal semen is seen in 12%.
So 48, who will answer 48? Volunteer?
Shall I do the question?
Yes.
A 29-year-old woman with bilateral tubal occlusion presents with 18 months of primary subfertility. A pre-treatment scan shows bilateral hydrosalpinx. Semen analysis is normal. What is the most appropriate management option?
Bilateral tubal occlusion, 18 months of primary subfertility, hydrosalpinx.
Recommended laparoscopic scalpellectomy prior to IVF.
Yeah, this is a gift question actually. The answer is B. Okay.
B.
Yeah. Next.
Bilateral hydrosalpinx.
Yeah. So which of the following statement 49 regarding treatment with clomiphene is incorrect?
Pregnancy rate after 6 cycles is 50%. That is okay. Side effects include consequences. Multiple pregnancies.
Other please mute other. So the question.
Which of the following statements regarding treatment with clomiphene is incorrect? The pregnancy rate after 6 cycles is 50%. Actually per cycle is 15%. No.
So the
cycle is
correct,
15.
the answer is what for this question?
C. Answer is C.
The answer is
D.
D. D. D. Approximately 60 to 70% of women will ovulate. This is the incorrect because, yeah, because as we know, it is 80%. Can reach to 80% with clomiphene citrate to be will ovulate with clomiphene. Okay.
Dr. Rasha, it is between 60 and 80%, huh?
It is, yeah, 70 to 80. 70 to 80.
70 to 80.
What about
actually it is 80%. I will mute other, sorry. Of course. Yes.
Sorry, Doctora, for question 49.
Rasha, what about
is it option
C option?
The answer here is here. You mean for question 49?
Yeah, is it option A is right? Is a pregnancy rate after 6?
No.
Is it true? It is not true, I think.
It is not true. Yeah. No, it is true.
It's true.
After 6 ovulatory cycle is 50%. This is true.
Yes.
This is true.
Okay.
Yeah.
Okay.
Because it is per cycle is 10%. The pregnancy test rate per cycle is 10%. So after 6 means that's 50%, nearly 50%. Okay.
Okay.
Please, I mentioned it in the last session. If you listen to my last session, the previous session. Okay. Next, who is volunteer?
Rasha, can you explain the third option? Risk of multiple pregnancy. Risk of multiple
even
pregnancy.
you mentioned risk of multiple
is it
pregnancy.
Not incorrect?
Yeah. No. Multiple pregnancy. Where is multiple pregnancy? Up to
6 to 11% you mentioned.
We tell 6 to 11% before. It is not right.
Yes.
Yeah. Next question. Who is volunteer?
Shall I read?
Yeah. Yeah. Sure.
Hello. Okay.
A 31-year-old woman presents to the accident and emergency department 3 days following an oocyte retrieval
The previous one. Question 50. Yeah.
Okay. Which one of the following is not a risk factor for ovarian hyperstimulation syndrome? PCOD, multiple pregnancy, HCG administration for luteal support, high serum estradiol on the day of HCG trigger injection, BMI of more than 30, younger age.
Not a risk factor for OHS.
Not a risk factor.
Multiple pregnancy.
This is BMI more than 30.
Yeah, so the answer is
E.
Yeah, BMI more. Yeah, exactly. Not a risk factor, which is the BMI of more than 30. The age, the BMI is not related to ovarian hyperstimulation. Okay.
What about young age, Dr. Young age? Dr. Rasha?
It is a risk factor in ovarian hyperstimulation,
Huge
actually, young age.
risk factor, younger age.
Yeah. Okay. Yeah. We mentioned it today. Okay.
Rochana?
We mentioned it today.
A 31-year-old woman presents to the accident and emergency department 3 days following an oocyte retrieval procedure. The patient is complaining
Sorry.
of... Oh, it's went off.
Sorry.
معلش دكتورة رشا, the previous question, what's the answer? It's not
The
young
answer is
age?
E. BMI more than 30. Young age is a risk factor.
Okay. Okay, thank you.
51 question number. A 31-year-old woman... A 31-year-old woman presents to the A&E department 3 days following an oocyte retrieval procedure. Patient is complaining of abdominal pain, vomiting, dizziness, shortness of breath. You are on your way to assess the patient. What would you want the emergency attendant to do while waiting for you to arrive? Attach a pulse oximeter and echocardiogram, administration of analgesics and an antiemetic, administer intravenous albumin, admit to the hospital and IV administration of 2 to 3 liters of fluids, arrange urgent abdominal and chest ultrasound evaluation, arrange a chest X-ray and ECG.
A option. Attach a
A
pulse
is the right
oximeter
answer.
is
D.
no A.
Oh, yes, D. I think D.
What would you want the emergency attendant to do while waiting for you to arrive?
She's having abdominal bleeding. Wait.
OHS. It's a manifestation of OHS.
Mild OHSS, we will go for administration of analgesics and antiemetic A.
Yes, A, Doctor A attach pulse.
Hello?
Dr. Rasha, sorry, what is the answer?
Echo, pulse oximeter, administration of analgesics and antiemetic, mild OHSS.
Why not
This
albumin?
patient is following oocyte retrieval procedures, and I think this is she's having bleeding. This patient.
OHSS?
No, she having OHSS.
OHSS. Then why no albumin? Why no IV albumin?
Why OHS?
She went for oocyte retrieval procedure means she went for ovarian stimulation. She is in mild
retrieval,
OHSS.
but I mean the retrieval procedures per se, it might cause bleeding. This patient coming with vomiting, dyspnea, shortness of breath.
No mention for bleeding
she needs
here.
urgent abdominal ultrasound
No mention for
to
bleeding. This is
determine if
case of
she has
OHSS.
Sorry, but because I have a call. Yes, we are in 52. Who will for 52?
51 answer is A,
Dr.
doctor.
Rasha, sorry, can you answer question 51, please?
51, okay. So, what is your answer?
A.
A. Mild OHSS.
It is A. Attach a pulse oximeter. This is the answer. Your answer? Hello?
Yes,
doctor.
Correct.
Yes,
Yeah, it is
doctor.
correct. Correct, yes. This is attach of a pulse oximeter and electrocardiogram, administration of, it is the ABCs, okay? Like the ABCs, okay? The first things you will do. Next.
Dr. Rasha,
52.
this is case of severe ovarian hyperstimulation syndrome.
What he said here, if we want to classify it, patient complain of abdominal pain, vomiting, dizziness, shortness of breath. Shortness of breast means that this is critical, the last one, the more severe one. Yeah.
No, this is after retrieval. She came to the exit to the emergency following oocyte retrieval procedure.
Okay. Complaint of abdominal pain, vomiting, dizziness, and shortness of breast.
Okay.
Dr. Rasha, why it is not like a accident, torsion accident?
No,
Because
most
she's
likely
having
this is ovarian
severe abdominal
hyperstimulation.
pain. Yes, I
No,
know,
this is a
Doctora,
feature.
but because she presented in a very severe sudden onset.
Yeah, we can rule it, but this patient actually, she had a risk factor for this.
OHSS.
Yes. Yeah,
They
there's a
did
risk
not
factor in
mention
this
the
case.
severity of the pain there. They just mentioned abdominal pain.
Yeah, this patient actually, it most likely the shortness of breath due to accumulation of large amount of acidic fluid.
In ovarian torsion, there won't be shortness of breath. There will be severe
no
pain,
shortness of
faint.
breath. Severe
No
pain,
shortness of breath.
rebound also. Yeah.
This is of OHSS, fluid accumulation in the lungs, RDS.
Question is regarding what we will do to the patient before we attend the hospital. So the answer goes with A.
Yeah, A. The answer is A. Yeah, exactly.
Yes. Shall we do 52 question next?
Yeah. So 52. Let's go fast because maybe some of you become upset, but just I want me also. I spend a lot of time, but just I want to finish with you so that you will not forget this question with this discussion. Okay, just go fast.
Okay, doctor. Severe
52?
ovarian hyperstimulation syndrome. Yeah. Severe OHSS is a recognized serious complication of fertility treatments. What is the triggering factor for this condition? Administration of HCG for follicle maturation, embryo transplant, failure to monitor serum estradiol and perform proper ultrasound folliculometry, inappropriate evaluation of the patient prior to treatment, use of large doses of gonadotropins for ovarian stimulation. E.
So the answer is
E.
A.
A.
C.
Administration of HCG for A.
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 The answer is A, aneuploidy of the embryo. Am I right?
Follicle
Yeah, the answer
maturation.
is A.
Administration.
Yeah,
No,
answer is A.
52. The question 52, Doctora.
The answer is not A.
The answer is A, aneuploidy of the embryo. Okay. Next.
52. Question number 52.
No, the
Doctora,
question
52.
We are answering 52, Doctora.
52. Okay.
Yes.
Okay. So the answer for 52 is, what is your answer?
Read the question again, Doctora. Severe again.
A.
Yes, answer A.
The answer is A. Yeah.
Why not E?
Most likely it is because of the SCG. Most likely the SCG is the cause, the recognized cause of the ovarian hyperstimulation. Okay?
Yeah.
Yeah. Next, please. Volunteer.
A 29-year-old woman with primary infertility due to tubal obstruction has undergone 2 trials of IVF with no success. Ovarian response and embryo cleavage had always been good. Previous ultrasonography and hysteroscopy were normal. Her partner's semen analysis is satisfactory. Karyotyping for the couple is normal. What is the most probable cause of failure of implantation in this patient?
So the answer is
Fluid in the hydrocephalus binding to the uterus.
C. Any IVF with failed embryo transfer, we have to rule out the tubal cause.
The most probable cause of failure of implantation in this patient is what?
Tubal cause, hydrosalpinx.
No, it is aneuploidy of the embryo. Hysteroscopy and ultrasound, all are normal.
Yes,
Most likely
all
it's
are normal.
aneuploidy of the embryo, okay?
But karyotyping for the couple is normal.
Karyotype is normal for the couple, but the aneuploidy of the embryo, it can be.
Okay.
But the patient has come for with infertility with tubal obstruction.
Yeah, but here, if it is written to you, it is not written that there is a hydrosalpinx. Ultrasound and hysteroscopy not mentioned that there is hysterosalpinx.
Okay, doctor.
Next.
Doctora, in IVF, we are not doing karyotyping or pre-implantation genetic diagnosis before to increase the success.
No. There is no.
Just
this is just in the lecture of the session of the Dr. Abtihal regarding the miscarriage. You remember if you were there, if you are in her session, if you listen to her, she actually offered karyotype for the recurrent miscarriage. Okay.
Yes.
Okay. Next.
A couple have been trying to achieve a spontaneous pregnancy for 3 years. The female partner is 37 years old and was diagnosed with endometriosis stage 3. IVF?
What is the answer? Yeah, IVF means that.
IVF?
Yeah. Proceed to IVF. Next. Mm-hmm. 55.
A 35-year-old infertile patient is classified as having stage 1 endometriosis and was prepared for IVF treatment. After counseling regarding the treatment, she asks you some questions. Which of the following statements regarding IVF is correct? Clinical pregnancy rate for IVF is reduced in endometriosis. Miscarriage rate is higher than average in patients with stage 1 endometriosis. Ovarian stimulation could make the endometriosis condition worse. Stage of endometriosis has no impact on the number of number of oocytes produced. Studies have shown lower fertilization rates in stage 1 endometriosis. However, implantation and clinical pregnancy rates are not affected.
So the answer is E. Yeah, exactly. Is that studies shown lower fertilization rate in stage 1. However, implantation and clinical pregnancy are not affected. Answer for 53, one of the chat answer asking, it is A. Answer of 53 is A. Okay. Next, 56.
A 27-year-old woman
if you get tired or something like that, you can stop.
No, please continue.
Continue,
Stop
please.
when يا رشا. Asli.
Sorry, Dr. Rasha, sorry. Maybe you are tired.
No, for me, no problem. Just maybe you, because this is your precious time, as I know. Maybe you
Actually, Dictora, you are giving us your time because, of course, this is benefit of us. But you are the one who's giving us your precious time.
Thank you so much. I hope all of you, inshallah, you will do it. Inshallah, bismillah.
Amen.
Thank you so much, Dr. Rasha. You will really appreciate your effort. There is a lot of information you gave to us. We really don't know. Thank you so much.
Yes, thank you so much.
It is very much quick revision and it is really very helpful.
Thank you so much to all of you. So question 56, we answer it or still?
A 27-year-old woman fails to conceive for 4 years. She is a heavy smoker with oligomenorrhea. BMI is 37. First line of management. Diet control for weight reduction and advice to stop smoking.
C. Or
diet control.
C.
She's BMI is 37, and she's heavy and oligomenorrhea. So what you want to do first?
C.
C.
But there is something you want to rule it.
Pelvic
Pelvic
ultrasound
With
ultrasound
and
reduction
urinary
can
measurement of
resume
serum
her
testosterone
cycle.
prolactin hormones.
I think the answer is E, because you want first to maybe she had PCO, this patient, because this is characteristic of PCO. Yeah. Okay, according to Rotterdam criteria. Yeah, because remaining
So diagnosing is first thing.
Yeah, E. The answer is E, because you have oligomenorrhea, which one of the criteria for the Rotterdam. So you need testosterone and pelvic ultrasound, rule out PCO. Okay?
Okay, doctor.
Dr. Rasha, can you show me the question 555, please? Just only I want to take screenshot.
This one. Okay.
Okay, thank you.
You're welcome. 57.
A 33-year-old woman is contemplating IVF for the third time. Patient is worried about the risk of developing ovarian cancer in the future due to repeated administration of fertility drugs. Which of the following statements is correct? Assisted reproduction medications increase the incidence of ovarian malignancies developing at a younger age. Collective evidence denies any correlation between IVF drugs and an increased risk of ovarian cancer. Only females with BRCA1 or 2 mutations are at a significantly higher risk of developing ovarian cancer following the use of fertility treatments. Recent evidence suggests an increase in benign ovarian lesions and a reduction in incidence of ovarian malignancies following IVF treatment. Studies confirm the positive correlation between fertility medications and the incidence of ovarian cancer. I don't know the answer, doctor.
The answer is
Is it D?
B. Yeah,
Increase
excellent.
in benign.
I think B.
Yeah, B, which is there is no any relation. Collective evidence
denies
yeah,
any correlation.
Yeah, between IVF and increased risk of ovarian cancer. Okay.
Okay.
Next, what is the incidence of premature ovarian insufficiency? We said this, I think, before.
1%. 1%, yes.
1%. Yes. Yeah.
1%.
Rasha, 57 answer, please. Is it D 57? Or E?
No, it is 57. It is
D.
B. B for boy. Okay.
B. Okay.
58. It is B. 1%.
1%.
This is given a picture of hysterosalpingogram. What is the most likely urinary tract anomaly to associate with this condition? It was
renal
this one.
agency.
Yeah, renal agencies. And what is the most likely urinary tract anomaly with it? The renal agency. Okay.
وهي الروتينات كاوسر هوستر syndrome.
Yeah, Mara. Yeah. 60. Who want to read the question 60?
Infertile women, man, severe oligo of 1.5 million with small testes, increased FSH-LH ratio. Woman has regular periods. Progesterone level is 30. pH of chlamydial infection. What is the most appropriate next step in management?
So,
chlamydial infection, lap and dye.
Karyotype.
Is it karyotype?
The answer is testing for karyotype. Am I right?
Small testis with oligospermia.
Yeah. So the answer is A.
Okay.
Next. 51.
Infertile couples, man, azoospermia with increased FSH-LH. All women tests, including tubes, are normal. Their best option is
IUI with the donor semen.
Donor semen.
C. with donor.
C. It is C. Yeah, exactly.
C,
it is IUI with donor semen. Yeah. Okay.
62.
Next.
Infertile couples, Man previously fertile but now azoospermic with decreased FSH. Possible cause.
What is the answer for 61?
Anabolic steroids.
Anabolic steroid.
D.
Yeah, anabolic steroid.
Dr. Rasha, sorry, about 61, why not IVF with donor sperm? Why IUI?
Most likely, he didn't tell you about the woman.
Women are
Why
normal.
IVF? Why IVF?
Because women normal. That's why IUI.
Yeah, because woman is normal. He didn't mention about the woman. If the woman is abnormal, at that time we will go for IVF with donor sperm. Okay? Yeah.
Okay.
Next.
Question number 63. Young couples trying for 2.5 years. All are normal. Best option offer IVF.
Yeah. Exactly.
64. A couple has to consult you regarding the NHS funding for IVF. They have been trying to conceive for 3 years. Female partner is 33 years old. Male partner has an adopted child because of failure to conceive in a previous relationship. They have not had any funded procedure previously. What will you tell them? Cannot be funded until they try for 2 more years. Cannot be funded because they have a child in the house. Cannot be funded until she reaches the age of 34. Can be funded if the anti-mullerian hormone is more than 5.4 picomoles per liter. They can be funded.
Yeah, exactly. What we
adoption.
tell today? What are the criteria?
B. Child adoption.
Yeah, because they have a child in the house. So means that it is most likely this baby is related to them or for her or related to the mother or So most likely the answer is B.
Existing child. B.
Yeah, because they have a child. Okay, so will not be funded. Okay, next.
Question number 65. Shall I continue, doctor?
If you want, or other, no problem for me. Just if
yes.
you want to finish.
A general practitioner.
Thank you.
I will remember the questions if I read. A general practitioner requests you help. A man has
At
just
any time,
come back from a business.
if anyone want to become a volunteer, no problem. You are welcome.
Yes. They want me only then. A general practitioner requests your help. A man has just come back from a business visit to a region infected with Zika virus. Man and his wife are wishing to try for pregnancy. Couple are free of any symptoms. What would be your recommendation? Man is advised to have a blood test for the Zika before any decision is made. Man is advised to have a course of antiviral therapy. Man is advised to use contraception for a period of 8 weeks. Couple is assured that Zika is not transmitted via semen. Couple can try artificial insemination with washed sperms.
C.
So the answer is
avoid pregnancy for two months. Yes.
8 weeks.
Yes.
C.
For 2 months.
Yeah. So the answer is C.
C.
Yeah. Exactly.
Actually, it is 12 weeks, no, doctor?
Yes,
Yeah, but
Doctor.
The new guideline for Zika is
Actually,
yeah,
it is
but
12
this is
weeks.
the nearest answer.
Asymptomatic.
Man,
They are
man
asymptomatic.
plus woman. If they go 12 weeks. Only female, 2 months.
8 weeks.
Yeah.
8 weeks.
They are well.
So answer is not C now.
No symptoms. They are well.
So next, 66.
Please, what's the
What
answer
is
for
the answer,
65?
doctor?
65.
The answer is C. The answer is C. Okay. Next.
I read, Dr. Rasha?
From the,
Yeah. Next question, please.
from
Dr. L2.
from the
65
following
is C.
combination, what harmony?
Yeah.
From the following combination, what hormonal profile is consistent with WHO class 3? It is high FSH and high
C.
LH and low estrogen. C.
Yeah. C. Exactly. Excellent. Next question.
one is 67. According to the WHO criteria, what is the reference limit for the total number of spermatozoa in an ejaculate? That is
D.
39 into 10 power 6 D.
D. 39 by 10. Yeah, exactly.
D.
Yeah, exactly.
Yeah.
Yeah, just I want you to remember. Anyone can tell, or you can tell me the other parameter, so
Yeah,
not forget.
the quantity of semen is 1.5 ml. The pH is 7.2. The sperm number is 15 into 10 power 6 per ml, and the sperm count is 39 into 10 power 6 per ejaculate. Motility is progressive 32%, and the morphology normal forms is 4% according to WHO criteria.
Okay. Okay. Next question. Thank you.
Which form of contraception is most strongly associated with a delay in return of fertility? Dipomethylhydroxyprogesterone acetate. B.
Yeah, exactly.
B.
Excellent.
B.
Yeah, B. Next.
B. D is the
69, right?
Yeah, 69.
35-year-old woman is diagnosed to have hypothalamic hypogonadism. She would like to conceive. What treatment would you administer to stimulate ovulation? It could be gonadotropin therapy.
Pulsatile GnRH.
Pulsatile GnRH. E.
Yeah, the answer is E because this is hypothalamic hypogonadism. So means that
Hypothalamic hypogonadism.
yeah, it is hypothalamic means that
Sorry.
pulsatile GnRH.
Sorry,
Yes,
Doctora.
what's your answer?
67, Doctora. What is the answer? Sorry.
67, as we said before,
D.
it is D, 39 by 10.
D.
Okay. D, okay. 70.
Comparing letrozole with clomiphene in patients with PCOD, clomiphene is associated with options: lower live birth rate, lower rate of multiple pregnancy, lower incidence of ovarian hyperstimulation, better side effect profile, higher implantation rate.
So what is the answer?
Lower incidence of
A.
Yeah, the answer is A. Lower
live
birth rate. Yeah, exactly. Okay. Other volunteer. Just remaining, I think, 20 questions. We want to go fast.
I read Rasha.
Can I?
A 29-year-old with primary subfertility and a BMI of 30 kg per meter square is known to have polycystic ovarian syndrome. Based on the anovulation, transvaginal ultrasound appearance of the ovaries and a raised testosterone, she has remained anovulatory despite increasing dose of the clomiphene citrate over the 6th cycle. What is the most appropriate next step in the management options? IVF is unstimulated.
Gonadotropin, doctor.
Gonadotropin.
Yeah, exactly. It is
Yes,
gonadotropin.
this is gonadotropin.
Yeah. Excellent. Yeah. Next.
A 25-year-old a 25-year-old athlete with a BMI of 18 presents to the fertility clinic after trying for a pregnancy for 2 years. She has oligomenorrhea and her partner's semen analysis is within the normal range. Her gonadotropin's profile shows a low FSH and LH. The estrogen levels are also low. Although the androgen is normal.
Profile is normal.
What
Androgen
is
profile
the
is normal.
Lifestyle intervention and HMG. B. Normal.
For the solution. This is clomiphene citrate lifestyle intervention, normalizing weight and exercise, and human. This one B is the one because it's hypogonadotropin.
Exactly. Excellent. Yeah, it is B. Yeah. Okay.
Please
clarify, please, Doctora.
This is the patient, 25 years old, athlete, means that type 1. Okay, means that type 1 with BMI of 18 present to the fertility clinic after trying for pregnancy for 2 years, and she had oligo. Even if she's trying for 2 years, but she has a problem, okay? Which means that type 1 ovarian failure WHO by WHO definition. She has oligo and her partner semen is normal. Her gonadotrophin low, FSH and LH, and the estrogen level are also low. So you will go for immediately for normalization of her weight and exercise, plus human menopausal gonadotrophin because she has a low FSH and LH. Okay? The answer is B.
Okay, thank
Clear
you.
now? Yeah. Next.
A 35-year-old para zero. This one or this one I have to read. A 35-year-old para zero is in the middle in the I cannot read. Okay, what is it again?
76, Doctora, 76. 73.
36 para one is undergoing an IVF cycle. She has egg retrieval and 2 fresh embryos are transferred. Her initial beta HCG is 1600 millinational unit per ml, and she begins to develop abdominal pain, nausea, and vomiting. And ultrasound reveals 2 gestational sacs and 3 abdominal fluid. Uh, she is not short of breath. Her pulse oximetry is 98% on her breath and height. And liver functions are within
Please.
normal limits.
Yes, you can complete.
What
Yes,
grade of
Shazia?
what ovarian hyperstimulation syndrome should she be categorized as?
Moderate.
So the
Free
answer is
fluid.
Moderate.
why moderate?
Because she has a cycle.
Ultrasound diagnosed ascites.
And ultrasound with ascites.
So as I told you in this question, always in the grading of the ovarian hyperstimulation, you had, for example, regarding the ovarian size, regarding the ultrasound finding, and regarding the hematocrit. This most likely pick this. If shortness of breath means that the last one. Okay?
Yeah.
So here is a moderate because ultrasound. Okay?
Because of ultrasound. This is
excellent. Yeah. Excellent.
A 35-year-old para zero. A 35-year-old para zero in the midst of IVF cycle. She has undergone egg retrieval following human chorionic gonadotropin administration, and you have just implanted 2 fresh embryos. She will stimulation syndrome. The chance is only.
So what is the answer?
Identified
0.3 to 8%.
What is the chance of developing ovarian hyperstimulation in this case?
30%.
35 years old, para zero,
Who
and
said
she has
30? Yeah.
chronic, and you just have plant. There is no risk.
Actually, it is D. Excellent. It is 30%.
Mild OH is 30%.
30%, huh? But this is.
So that's why you asking me before which one it is HCG or gonadotropin. It is HCG, the most likely cause of or the chance of developing more with HCG. Okay. Because it is 33%. Means that the nearest answer is 30, which is D. Okay, thank you. Other?
Can I continue?
A patient with. Anybody else want to read, or I will continue?
Yes, I can continue if others have a problem.
Is found to have tubal obstruction falling in HSG. There are no known additional pelvic comorbidities such as PID, previous ectopic pregnancy, or endometriosis. What is the chance that laparoscopy will confirm these? Will confirm these findings
of occlusion? Yeah.
Or findings of occlusion.
35%. Actually, it is 38%.
C.
So the answer is A.
I'm not sure, Dr.
Yeah, the answer actually is C. The answer is C because hysterosalpingogram is not a reliable indicator for tubal occlusion. But if it said that the tube are patent, means that it most likely it will be patent. It confirms at laparoscopy. Okay, this finding at laparoscopy. But actually, the chance of it to confirm the diagnosis or the finding of occlusion is 35%. Okay. Yeah.
Okay.
Next.
A 37-year-old para 0 who has undergone controlled ovarian stimulation for IVF treatment 3 weeks previously presents with abdominal pain, bloating, nausea, and vomiting. She is known to have PCO and had ovulated previously with clomiphene citrate treatment. She went on to receive antagonist recombinant FSH protocol and was later given human chorionic gonadotropin to trigger ovulation. Ultrasound has shown evidence of ascites with an ovarian size of 14 centimeter. Her hematocrit was 46. The patient was admitted to the hospital for inpatient treatment. What is recommended regime of thromboprophylaxis? Until she is admitted to the hospital or until the ovarian hypertension subsided. Until the ovarian subsided.
No, it is
No,
I
no,
said
no,
it is
A,
second today.
D,
A.
D. Till
It
the
should be
end of the
D.
first trimester.
For her
Yeah,
duration
I
of
said it
stay.
today. So it is for the rest 12 weeks. I mean for the 12 weeks, the first 12 weeks, the first trimester. Okay. Yeah.
Okay.
Next.
A
Want to continue
39
or any volunteer, other volunteer or anything? Just we have, I think now 13 questions remaining. Just let to finish.
A 39-year-old male presents to the fertility clinic following a repeat semen analysis for oligoasthenia.
Pirato. Teratospermia.
The semen volume 1 millimeters, sperm concentration 2 into 1, fertility percent, normal 1, vitality 10%. What is the appropriate next step in the management of the control?
C.
Testicular
Repeat.
Biopsy.
B. IVF using EXI.
IVF ICSI.
So what you will do?
IVF using EXI. B.
IVF using it. It is actually this patient. She had another answer. Any other answer?
IVF with donor sperm.
IVF with ICSI.
With EXI.
ICSI.
Why not testicular biopsy?
Biopsy.
Yeah, testicular biopsy. Because it is useful actually in form of severe oligospermia, and even it can be helpful. Yeah, facilitate the sperm recovery for ICSI.
Yes, testicular biopsy.
Yeah. Okay. So we'll start by the.
How to choose whether it is ICSI or donor sperm or testicular biopsy? How do we, which one
Because
would be?
here why we will not choose the IVF using donor sperm, because most couples prefer to achieve fertility with parental sperm from the first start, because we want to know testicular biopsy to know about the sperm. Okay. Before the ICSI. Yeah.
Okay,
and
thank you.
IUI, it is not suitable for severe oligospermia.
Rasha, why you need
طيب why not B, دكتورة رشا? Why not B?
Why not be IVF and XC? Because it is difficulty. There is a difficulty in taking a male sample. The egg retrieval. Okay? Yeah, there is difficulty in obtaining the sample of the male at the time of the egg retrieval day. So that's why we not choose this IVF with XC. First, we want the testicular biopsy to take the sperm first. Okay?
Okay, thank you.
It's clear for you?
Yes,
No,
doctor.
Asha.
Thank you so much.
I had a doubt. He had 2 million count now. We can use it for ICSI because he had 10% motile sperm and 2 million count.
Yeah, but most likely in UK, most likely the couple will not prefer this. Most likely they prefer the testicular biopsy because I mean this is for the IVF with donor sperm. But regarding the IVF with XC, because it will be difficulty in taking the sperm. So that's better to do it testicular biopsy first before you will go for XC. Okay?
That means you are telling micro-TISI.
Get the sperm and then inject it.
Okay, sperm recovery technique. Okay.
Yeah, first you take the sperm by testicular biopsy and then inject it. Yeah.
Okay. It's a fresh one or cryopreserved one?
Before we tell about through the tested and through the epididymis, T cell, me cell, these things. It is in my session, the first session. Okay, just see it. Next. Next, my dear.
A male patient present with history of anosmia and azoospermia, bilateral small testis and gynecomastia. What is the best treatment modality? Options A, bromocriptine, clomiphene, gonadotropin, letrozole, and testosterone replacement. Choices gonadotropin because it's
exactly.
a hypogonadism syndrome.
In my previous session, I mentioned this for the Klinefelter. This is hypogonadotrophic hypogonadism. And the clue here, as you see, anosmia, as I said.
Yes.
Next.
Kalman syndrome.
What is the answer, Doctora? What is the answer?
Kalman, I mean Kalman syndrome. Yes, Kalman, yeah.
What is the answer in the options?
The answer is C. Okay. The next question. So, who is volunteer for the next question?
After an IVF cycle?
I want to participate, but I have very poor internet connection. I can or
after an IVF cycle.
Welcome. Okay. You answer?
Hello, Rasha.
Yeah, welcome. Yes.
After an IVF cycle and a subsequently positive pregnancy test, a patient develops abdominal pain, nausea, vomiting, and mild shortness of breath. Further evaluation reveals normal lung sounds, palpable ascites, and pulse oximetry of 97% on room air. A chest X-ray is normal. The hematocrit is 40%. Ultrasound shows ovary of 9 cm with evident ascites. Which of the following is most consistent with severe OHS? Option: shortness of breath, hematocrit greater than 40%, palpable ascites, ovarian size greater than 9 cm, E, all of the above. Answer is palpable ascites.
Palpable ascites, exactly. Yeah. The answer is C. Okay. Answer is C. Next. Question 80.
Yes. A 40-year-old woman came to see you with her husband who mentioned that she lately developed acne and harshness of voice. She has grade 2 to 4 hirsutism. Testosterone is 11. 17 ketosteroids are normal. FSH, LH are normal. What is most likely cause? A. Androgen secreting tumor. B. Adrenal tumor. C. Cushing syndrome. D. PCOS. Androgen secreting tumor. Answer
A. Answer A.
The answer is
androgen secreting tumor.
Yes.
A.
yeah. So the answer is A. Yeah, exactly. Okay. Next question.
24-year-old.
The testosterone, it should be more than how much?
More than 5.
More than 5.
Okay, thank you.
You're welcome.
24-year para-zero lady attended the clinic with a history of failure to conceive for about 26 months despite having regular unprotected sexual intercourse. She does not have any significant medical history and has regular menstrual period. The mid-luteal serum progesterone concentration over 2 consecutive cycles are 33-36 nanomole per liter, and the HSC show bilateral tubal patency. Her partner is a 36-year-old gentleman who is generally healthy, smokes 20 cigarettes per day, drinks more than 12 units of alcohol per day, per week. He has a history of mumps when he was 16 years old. A semen analysis has shown absence of any sperm that has been confirmed by a repeat test. A serum FSH LH concentration are raised and the serum testosterone concentration is low. He has a normal karyotype and does not have Y chromosome deletion. The most appropriate actions for couple marriage should be antioxidant treatment for 6 months for male partner, donor insemination, HCG treatment for 3 months for male partner to stop smoking and drinking and to recheck semen analysis in 3 months. E. Testicular sperm aspiration with IVF with intracytoplasmic sperm injection.
Answer
Donor
insemination. Donor insemination?
Donor. B option.
Yes, excellent. Yes, it's donor insemination. Yeah.
B.
Yeah, the answer is B because most likely this raised FSH and LH and low serum testosterone indicate primary testicular failure. Okay, so this is most likely to
And does
be
not
related
have
to
Y
mom.
chromosome.
Yeah, to the mom. Okay. Yeah. So if you stop drinking, I mean smoking and drinking, it will not benefit from this. The man will not benefit from this. Okay. So
Yes.
it wouldn't be, yeah. So that the other option also it cannot be for this patient because IVF even he is a smoker. All these things will make IVF not eligible for IVF. Most likely the answer is B. I mean donor insemination. Okay.
Okay.
Yeah. Maybe I think this is the last one. I think yeah, this is the last one. Yeah. Okay. The last one. We will do this last one. This is no. I think this one you have to. Okay, yeah, this one.
Can I continue?
I think there is one who want to participate. If there is another one want to participate, yeah.
Yes.
Yeah.
Up to how many percentage of women with moderate to severe OHSS may require admission to the hospital?
Yeah. How much?
3%.
3%.
1 to 3% is only for
1 to
severe.
3. Yeah.
Yes.
So
N.
up to 1%.
N option.
N.
A. N or A. Both of them are true.
3%. So we will take the highest
We'll
range.
take a higher side.
N. 3%. N.
Yeah. And the next?
Undertaking ESET in approximately 50% of IVF patients will reduce the multiple twin birth rate to less than, I don't know really.
Yeah. To less than 10%. Okay.
What is the
The answer is 10%, which is M.
What is ESET?
Elective single embryo transfer. Euploid
Yeah.
single embryo transfer. Euploid single embryo transfer.
Yeah, single embryo transfer. Yeah. Okay. So undertaking single embryo transfer in 50% of IVF will reduce the multiple pregnancy to less than 10%. Okay, the answer is M. Next.
Oocyte retrieval is carried out how many hours after HCG injection? I think
34
after
to 37
34 to
hours.
37 hours. D.
Is H. Optimal endometrial. What? Just 1 minute. Oh, oocyte retrieval. Am I right?
86 hours.
Oocyte retrieval.
Yes. Yes.
84. How much?
34 to 37 hours. D, doctor.
Yeah, D. Yeah, D. Yeah, exactly. Okay. 85.
Frozen thawed embryo replacement increase the overall cumulative pregnancy rate by approximately
36%.
How much?
36.
25%, I think. 23 or 25.
I think 23%. 23 or 25%. This one
from
minute.
all
Anyone you want to
from
anyone?
where all this percentage, Doctor? Sorry, I didn't know any one of them.
This is actually strategy percentage.
Okay.
Okay. Yeah.
What
So
is
the
the
answer
answer,
is
Rasha?
what is the answer?
23%. 23%.
23%, I think.
Okay.
Just let me to just 1 minute. Just 1 minute. It is actually it is the overall cumulative. It is 11%. The answer is K. Okay, the answer is K. 11%.
K is 23, doctor. 11 is L.
23.
K
Yeah,
is 23.
23. No, 23%. Yeah.
Is
Okay. K.
23%.
Yeah, 23%. So the next question. 86.
NICE recommend BMI of female partner before commencing fertility treatment.
19 to 30.
19 to 30. E.
19 to 30.
Yeah, exactly. Okay, so the last one, the last EMQ, who want to participate on it?
I will do it.
Okay.
33-year-old woman has tried unsuccessfully for pregnancy for 19 months. She menstruates regularly every 24 days. Her blood progesterone obtained on day 21 was 20 millimole. Normal range is more than 30. Which option best describes the problem? Menstruation 19 months. She menstruates period. What is this?
What is the answer?
Anovulation. Anovulation.
Anovulation.
She's answer.
Not
Miss-
blood sampling. L.
The answer is mistime blood sampling.
Mistime blood sampling.
Yeah.
Okay.
Mistime blood sampling. This is the answer, which is L. Excellent. Yeah.
Yes,
Next.
29-year-old woman presented with an inability to conceive of 12 months duration since stopping the COCP pill after 6 years of use. She menstruates every 30 days, and her mid-luteal progesterone was 35. However, her TVS shows ovaries with polycystic appearance. All other tests, including semen analysis and HSG, were within normal limits. Which of the above is the best match? So she's ovulating and post COCP. Can I see the options, doctor?
So this is inability to conceive of 12 month duration.
Physiological amino no. I don't know.
Unexplained subfertility.
Unexplained subfertility.
Unexplained infertility. Yeah. Because why?
Because she was initially having regular periods, but after COCP, she could not.
Because because the polycystic appearance of the ovaries doesn't always imply or confirm that this is polycystic ovary syndrome.
No.
Okay. Yeah, it is normal size ovaries appear. Polycystic may result from many years of the combined oral contraceptive, as in this case. Because in this case, because of the a long time of using combined oral contraceptive, sometimes it can come like this. So ovaries appear like there is a polycystic appearance, but not polycystic ovary syndrome. Okay.
Okay.
What is the answer?
So the answer is, as she said, unexplained subfertility. Unexplained. Because it's not a case of PCO.
89. A 30-year-old Polish migrant.
We should follow Rotterdam. Yeah. Excellent, Fatma. Next.
A 30-year-old Polish migrant had massive PPH. Massive postpartum hemorrhage needing aggressive transfusion with 18 units of blood products. She had been referred early by her GP for advice because 4 months postnatally, she still had not menstruated. She breastfed on demand for 4 months but recently had to introduce complementary feeds. A urine PT was negative. Which of the following is best matched? PPH is a
She. Yes, what is the answer?
PPH is Sheehan syndrome.
Sheehan?
No, but she is breastfeeding, so it's not Sheehan. It may
not
be
Sheehan.
Escherman.
It's not Sheehan. What is it? Most likely it is physiological pregnancy. Physiological, I mean physiological amenorrhea. Lactational.
Okay.
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 The last question.
The last one is 90. A couple when the female part.
89 question. What is the answer, Rasha?
The answer is lactational amenorrhea, physiological amenorrhea, which is where is it? It is J. Okay, J. The last question.
Okay.
A couple where the female partner has complete Rokitansky syndrome with right renal absence. Unstimulated intrauterine insemination, surrogacy, stimulated IUI, oocyte, no treatment is available, ICSI. Surrogacy for Rokitansky syndrome. B.
Surrogacy.
So it is B. Yeah, exactly. And for the
Doctor, please show the previous question once. Previous question, please. 89.
Please.
Yeah, the previous question, as we said, it is J for the lactational amenorrhea. Okay. This one, the last one is the answer is surrogacy because it is this is MRCOG syndrome. For the Turner syndrome, you will choose egg donation. Don't forget. Okay.
Okay.
But doctor, in question number 89, after 4 months, she had recently had to introduce complementary feeds. She breastfed on demand for 4 months, but recently had to introduce complementary feeds with amenorrhea and history of PPH.
Yeah, but she's breast. If she's history of Sheehan, she will not breastfeed. She cannot breastfeed. This is what you want to decrease. You get me?
Maybe gradually decreased.
No, if she has Chihan syndrome, she cannot be able to breastfeed.
So there will be immediate effect of hyperprolactinemia?
No, here, yeah. This is she had the lactational amenorrhea, physiological, because of the prolactin. Okay? Because if she had Chihan syndrome, she cannot breastfeed, means that there is no prolactin. But here there is prolactin because she starts to breastfeed for 4 months.
Okay, doctor.
Dr. Rasha, can you go back to question 59, please?
59?
If she has
59, yes.
59.
Sorry, yes, I missed this question.
No problem. 59. Just 1 minute. Yes. This one, 59.
I think 60, maybe 60, what is the most? No, it's not 59. I think it's 60, please.
60?
Yeah.
60, this one 60, yeah.
What is the answer? Can you, Doctora, read this again and tell me the answer, please?
Okay. Infertile couple months severe oligo with small testes, increase FSH and LH. Women have a regular period, means that the women have nothing. And progesterone level 30, past history of chlamydia. What is the most likely next step in this management? What is? She had a severe oligospermia and small testes. You will do cardio because of time filter as more FSH. Okay?
Okay. Shukran.
What is after 59?
Doctor, what is the surrogacy?
Which one? 59? 59, it is renal agenesis because it is associated in
Doctora?
Sorry, I didn't hear you.
Doctora, what is the surrogacy?
Surrogacy means that there is another woman, okay? We will take, means that we will use the uterus of the another woman. Okay?
Okay.
Because this Mara, which is Maya Ruturinsky, she had an ovary. She didn't have uterus and blind vagina. Okay? So means that she has an ovary, means that she had an ova. The problem is for her is that who carries this pregnancy? She cannot carry the pregnancy. Okay? So we will bring another surrogate mother, according, of course, of a law in UK, because we have two types, either partial or complete surrogacy. Okay? And there is a rule for this. This is actually in the third part. Inshallah, if you pass, you will know all these things. Okay? Yeah. So surrogacy this is what we mean by surrogacy. Means that there is another woman, we will not pay for her much money. It is by the NHS, okay, through the NHS, and it is actually it will be she will carry this pregnancy. Okay.
يديك العافية دكتورة المعاصي حسنات شكرا لك ولوقتك.
Thank you all of you.
Thank you, Doctora. You simplified it a lot for us, wallahi. Thank you very much.
ربنا يرفع قدرك يا رب.
شكرا يا رجال.
Thank you. Just I want to give you advice to sleep well before the exam, okay? And trust yourself, you will do it, okay? And don't say that I will not read till the exam, and that the day of the exam I will be I will not read anything. No. Just just early, okay? And reach before one day of the exam to the area when you what you will do. I mean the area where you will go before one day, okay? And start in the exam, be relaxed, bring with you like chocolate or something like that, and also take your breakfast, and of course pray for Allah, in the exam, just relax and start with the EMQ. Okay, and actually each paper have 3 hours, means that you can spend like two hours or 1 hour and 40 minutes in the solving of the EMQ. This is normally. Okay, are you hearing me?
Yes, Doctor.
Yes.
Okay.
Okay, shukran,
Start
Rasha.
with
Thank you.
my yeah.
Thank you.
Thank you
If you
so
didn't
much,
know
Dr. Rasha. Thank you so much.
Thank you so much.
yeah, and hope all of you, inshallah, you will do it, inshallah.
Thank you, doctor.
Thank you so much.
Thank you, doctor.
Thank you, all of you.
Rasha,
And
one
sorry for
request. Rasha, one request.
Yes.
If possible, you'll take, this precise format of contraception?
What? I didn't hear you.
Contraception.
Yeah, what about the contraception?
No, class and contraception. We need like this.
Okay, we will try, inshallah. Okay.
Yeah, because we need a simplified format. Otherwise, it's very difficult to attend.
Yeah. Inshallah. Inshallah, we'll do it. Inshallah, we'll try for the exam. Okay. Thank you, all of you. And I hope you will do it. Just trust yourself. And all my best wishes for you.
Thank you,
Thank
Doctor.
you so much.
Thank you, Rasha. Thank you.
Thank you, my dear.
دعواتك يا رشا، دعواتك.
Inshallah, you will do it. Inshallah. Bismillah. Bye bye.